Good afternoon and welcome back from our lunch break to the 174th Vaccines and Related Biological Products Advisory Committee meeting, day 2. I'd now like to hand this meeting over to our chair, Dr. Monto, and as well as Peter Marks. Take it away, Arnold.
I'd like to welcome you back and to the open public hearing session. Please note that both the Food and Drug Administration and the public believe in the transparent process for information gathering and decision making. To ensure such transparency at the open public hearing session of the advisory committee meeting, FDA believes that it is important to understand the context of an individual's presentation. For this reason, FDA encourages you, the open public hearing speaker, at the beginning of your written or oral statement to advise the committee of any financial relationship that you may have with the sponsor, its product, and, if known, its direct competitors. For example, this financial information may include the sponsor's payment of expenses in connection with your presentation in this meeting. Likewise, FDA encourages you at the beginning of your statement to advise the committee if you do not have any financial relationships. If you choose not to address this issue of financial relationships at the beginning of your statement, it will not preclude you from speaking. Dr. Marks, please.
Thanks very much, Dr. Monto, and thank you to the open public hearing speakers. As noted, FDA welcomes comments from interested members of the public during the open public hearing portion of the advisory committee meetings. We welcome and respect the input about the topics being discussed at today's meeting, but we don't in any way accept or condone comments that include offensive remarks or hate speech, particularly any such remarks directed at a member of the advisory committee or FDA staff. Thanks very much.
Thank you. This is Bravo Acharya. Before I begin calling the registered speakers, I would like to add the following additional guidance. FDA encourages participation from all public stakeholders in the decision-making processes. Every advisory committee meeting includes an open public hearing session during which interested persons may present relevant information or views. Participants during the OPH sessions are not FDA employees or members of this advisory committee. FDA recognizes that the speakers may represent a range of viewpoints. These statements made during this open public hearing session reflect the viewpoints of the individual speakers or their organizations and are not meant to indicate agency agreement with the statements made. With this additional guidance, I would like to now call upon the first speaker, Dr. Jasmine King. You have 3 minutes to speak.
Hello, I'd ask my first and only slide be presented. My name is Jasmine King. My health and life have been completely altered since July of 2021 when I received the single Moderna vaccination. I was 38 at the time. It does take an awful lot of courage to open up to a group of strangers about such personal matters. Then again, the life-threatening health issues I'm facing have evoked a level of courage and bravery I could never before have fathomed. Before this vaccination, I was active, energetic, upbeat, and my husband and I run an organic farm, I as the grant writer attorney. I ran, taught yoga. I very recently had 2 natural births and was breastfeeding my 1-year-old at this time. I ignored the initial hit the vaccine took on me regarding this as, quote, to be expected, but the compromise on my immune system started showing within days. I had previously been able to avoid the dozens of annual colds my 2 toddlers get, but after vaccination, I quickly caught their colds. This happened again and again. Then a topical fungal infection, And a few weeks in, I began experiencing subtle muscle spasms and sensory issues. I constantly felt unusually hot, burnt on my skin, or as if something invisible was crawling on me. How odd, I thought. I had no idea my nervous system seized, which culminated explosively 2 months later. My back, arms, face burned as if scorched by fire. The pain went deep into my muscles. Zaps and booms were sounding in my head. My glands all swelled up. My sweating became abnormal, making me intolerant to heat, and my heart rate doubled. Electric pins and needles, twitches and muscle spasms that were strong enough to jolt me in my sleep passed over every body part for weeks, and it was all so aggressive that I could not sleep for 6 weeks. Then in late December, notable muscle wasting or atrophy began, and it began in a painful manner. Well, I'm told that Moderna's trials resulted in absolutely zero neurological adverse effects. There are thousands of individuals like myself. I found this out after testing positive, eventually that is, for an antibody related to sensory and neuromuscular issues. I initially joined a Mayo patient support forum, then found other similar forums where these vaccine-injured individuals are congregating for peer assistance. I also learned this upon trying to get into several prominent neurology clinics, and they're all backed up. Many of those injured experienced these side effects long before I was vaccinated, yet I wasn't afforded this knowledge. No disclosures, no PSAs from federal health agencies, and no media coverage about this whatsoever. Apparent from where I stand is a missed opportunity to collect and act on neurological vaccination risks in the non-trial population, to inform the public and disseminate the trend to medical providers, particularly neurologists. This lack of dissemination hurts my ability to be quickly treated, and I'd like everyone to understand that it affects at the patient level. Now, I also see from where I now am that it is slightly odd and flawed to rely so extensively on self-reporting when persons like myself are going through crises that compares to nothing I've ever been through in my entire life. But it is even more flawed to sit on this data of the non-trial population for years to later do a look back. I believe this is the approach right now that explains why there's so little discussion of this. I understand from a statistical standpoint, but given what is at stake, I do not understand. Excuse me?
Can you please wrap it up?
Absolutely, yes. As you contemplate the decisions ahead, please keep in mind that there are mandates and immense pressures involved here. I believe there's more room for pairwise comparisons. For example, looking at my age group and health profile, I had minimum risk from the virus itself. How does this apply to young children? Likewise, just because of vaccination, that there's a lot of looking at the hospitalization rates of virus versus vaccine, but you take a case like mine, I haven't been hospitalized.
Ma'am, you have to end it here, please.
Okay, well, thank you all.
Okay, so the next speaker is Dr. Ashley Serrano. You have 3 minutes.
Hi, I have no conflicts. My name is Ashley, and I am a mother of a 3-year-old, as well as a clinical psychologist who focuses my work on evaluating and treating youth. I am here again today to strongly urge the community to recommend emergency use authorization for both Pfizer's and Moderna's vaccines in children under 5 years. As I mentioned yesterday, when I was referring to children under 5, Moderna easily met immunobridging endpoints after just 2 doses for the 5 and younger age group. This will give our children full protection more quickly when compared to Pfizer's vaccine, which means they would start the school year fully vaccinated. And that's really great news for my daughter. For children 6 months to 5 years of age, Moderna's 2-dose series also showed improved efficacy when comparing it to Pfizer's data against Omicron after 2 doses. We know both these vaccines would eventually require what we now call booster doses, implying a 3rd dose for Moderna and perhaps a 4th for Pfizer. Next slide, please. It took me a long while to conceive my daughter, but it wasn't without the help of amazing scientists within the infertility world to help me. These are just a few of the supplies I used throughout the many months of infertility treatment. Many other of these supplies would have been in various airports and hotels, as we are a family who love to travel. This is also me the night before I was rushed to the hospital via ambulance, and little did I know that I would be meeting my daughter just a couple of days later. Who could have known that after my daughter's first Christmas would be her last time visiting most of her family members for over 2 years? She was just an infant the last time she saw them in person or at all. You should see her face when she gets to see her family members via video, and I can only imagine what it will be like when she gets to see them in person once she is fully vaccinated. Slide 4, please. When I had my daughter, I had so many dreams for her and couldn't wait to share all of the experiences with her. It was already sad that we didn't have Toys R Us, but once March 2020 came, we lost so many other opportunities to visit family in other countries and states, swim lessons, birthday parties, and the list goes on. I never would have thought I'd have to take more than normal precautions at a lake or a playground to protect us from potentially fatal illnesses. It has always been my goal to protect her, ranging from proper prenatal care to wearing sunscreen to receiving all the vaccines to protect against potentially fatal diseases. As a 3-year-old, she is now asking to go inside stores, restaurants, and people's houses, all things that were completely normal for us at 3 years old. But I often have to say no because my job is to protect her. All she wants to do when she is vaccinated is to go into a restaurant and have an indoor Elsa birthday party. As a clinical psychologist, I evaluate 0 to 5-year-olds for autism. When COVID-19 came, I collaborated with colleagues to create a virtual evaluation to allow these children to obtain appropriate treatment. We continue offering these virtual evaluations because this age group can't be vaccinated yet. Many families don't feel comfortable taking their unvaccinated children to playgrounds to strengthen their skills. We continue offering telehealth, but what happens when telehealth is no longer covered by insurance or when the public health emergency expires next month? Now is the time to approve these vaccines for this age group. Finally, while many people resume life as normal, there are many kids and teenagers who have not. My family has not, since my 3-year-old continues to be ineligible for the vaccine 399 days since our teenagers became eligible to be vaccinated. Let's help our future generations start living now and allow them to be protected against the harms of COVID-19. Thank you.
Thank you. The next speaker is Mr. Michael Baker.
Good afternoon, members of the committee. Thank you for listening to my statement. I have no financial conflicts of interest. I'm a father of 2 wonderful children, ages 1 and 3, and I would like to take a moment to talk about how the past 2 years have impacted our lives. This slide is a non-exhaustive list of some of the things that we have missed out on. And although what I've shared here is specific to my family, our experiences are in no way unique. Our children have all, to one degree or another, been subject to the largest social experiment in history, and it will be many years before we fully understand the developmental impact that this pandemic has caused. My wife and I have had to continuously weigh the risk of disease against the risk of stunted development for our children, and every single day I fear for them. I want to make the best choices for my children as I possibly can, and I ask myself constantly, have we made the right choice? And yet, for all of that burden, I am endlessly grateful. We have been incredibly privileged to have had the option to make these choices. Not all parents in our position have had the choice to do what they thought was best. This problem has only become worse. Pediatric infections have skyrocketed as the rest of the country has in many ways completely moved on. All I am asking is now that the rest of the country can choose not to care about COVID, that I have the choice to vaccinate my children, and I have the choice to do it in the most timely fashion possible. We have utterly failed as a society to protect those among us who cannot protect themselves. There have been, as you know, nearly 1,600 pediatric deaths due to COVID-19 as of June 12th, thousands more hospitalizations, and an unknown number of future potential complications. As we can no longer rely on any sort of layered mitigation to control the spread, vaccination is our last remaining hope. It must be offered as an option with all due haste, and this committee should consider the differences between each vaccine through a lens of equity. There is a vast difference for working families between making it to 2 appointments versus 3, and there is a vast difference in waiting an additional 7 weeks to be fully vaccinated. I have been listening to today's meeting, and I want to reiterate that I understand a booster dose will likely be needed at some point. My primary concern as a parent is not to avoid symptomatic illness. It is to keep my children out of the hospital and safe from serious harm. My wife and I have succeeded in keeping COVID out of our household thus far, but now we are calling on you to help us take one small step back into normalcy. We are asking for options. For us, the superior option will be vaccination with Moderna. For others, it may be Pfizer. We ask that you afford us and all parents who wish to protect their children the possibility to make that choice now. Thank you for your time.
Thank you for allowing me to speak today. I have no conflicts. My name is Fatima Khan, and I am a mother to a 6- and 4-year-old. I am also a co-founder of Protect Their Future, an entirely volunteer grassroots group of physicians, parents, and activists advocating for health leaders to prioritize children, including allowing our youngest equitable access to safe COVID vaccines. We receive no funding from any individual or corporation. Our group is composed of thousands of families who accept that COVID can pose significant harm to children and that vaccines offer a strong layer of protection against not only infection, but also long-term complications like MIS-C, long COVID, neurological effects, and in worst cases, death. Based on all available data, we support emergency use authorization for both Moderna and Pfizer's COVID vaccines. Our public health leaders have left families of children under 5 behind, making any semblance of a balanced life difficult to achieve. As a co-founder of Protect Their Future, I hear from families across the country struggling to keep their children safe while also balancing real-life necessities such as work, school, and other obligations. Not a day goes by that I don't hear of a parent lamenting that their child either contracted COVID or was exposed, despite taking all reasonable precautions. Each parent feels an overwhelming sense of failure and defeat because they weren't able to keep their child protected until a vaccine was available for their age group. We know that families of color and low-income families have greatly suffered. These are often the families who don't have the choice to keep their children home and who must make impossible decisions between protecting their loved ones and bringing food to their tables. Delaying vaccines to our youngest only exacerbates these disparities. Almost 8 months out from when children 5 and older could access vaccines, millions of children under 5 have been infected. Moreover, the majority of hospitalizations and deaths recorded in children under 5 occurred during the Omicron surge, a time when trials were meant to have already been completed in this age group. Any more death and illness for our youngest and most vulnerable is unacceptable. Every day of inaction leads to more suffering and damage. As others stated yesterday, Moderna was shown to not only meet trial criteria for the 2-dose regimen, but also had a higher efficacy rate against Omicron when compared to Pfizer's 2-dose series. It seems to be the case that Pfizer's efficacy improved significantly after a 3rd dose, and it can be inferred that a 3rd dose of Moderna, like boosters for other age groups, will yield even better results than the 2-dose regimen. Moderna also showed higher antibody levels after just 2 doses than Pfizer's 3-dose series. Trial and real-world data are proving Moderna may be offering superior protection. This is why it is critical to approve both vaccines today so that parents have options and so that our children can be fully vaccinated before school. If they need additional doses later, that can be evaluated as needed. Children like my daughter, who will proudly join the ranks of junior kindergarten this fall, must have the same access the rest of their school-age peers has. We have waited too long and too many families have suffered already. Please ensure that our children are protected with these highly safe and effective vaccines. Thank you.
Thank you. The next speaker is Mr. Nicholas Giglia.
Thank you for the opportunity to speak. I have no conflicts. I am Nicholas Giglia, father of 2 great kids, a supernaturally empathetic son, and an energetic and curious daughter who participated in the Pfizer trial. I'm so grateful we could contribute in a small way to this wonderful scientific achievement, and I look forward to one day telling my little girl how she helped save the world. It is vital to approve both these vaccines. The 3-dose regimen from Pfizer and the 2-dose regimen from Moderna have both met immunobridging, the primary goal of the study, without any major safety concerns. Moderna's 2-dose regimen would allow kids like my son to start preschool or kindergarten fully vaccinated, and the Pfizer vaccine provides protection spread out over 3 doses. Parents and children deserve a choice, especially since our only choice up to now has been hope and prayer. We have, through a combination of precautions, remote work, and luck, kept COVID at bay so far. This has come at a high price of my mental health, my waistline, sleepless nights, deferred dreams, and the childhood I wish I could have given my kids. Every decision requires detailed and exhausting risk calculation, and I wonder at every daycare drop-off if today is the day our luck runs out. When exposed, the kids are home for 7 to 10 days, where we have to be full-time employees and full-time parents while feeling like we're failing at both. We have navigated a world without protection or empathy, while those with the luxury have moved on from COVID. We have heard constantly that we have the tools to end the pandemic while we were prohibited from using these tools to protect our children. We must grant children under 5 access to these 2 safe and effective vaccines, especially during the surge. These applications are welcome, but this meeting should not be considered a victory. Our governments have abandoned the youngest children, allowing millions to be infected with a novel virus with unknown long-term effects without the protection vaccines offer. Process is important and necessary, but the circuitous route we've taken to get here, including unexplained trial expansions, canceled meetings, deferred applications, and almost a year of promises of relief in the coming weeks, has robbed this day of the joy I expected to feel. Real families have been impacted by every twist and turn in this process. In my line of work, it is vital to take an honest look at issues to prevent recurrence, and it must happen here as well. We must proceed for approval to detailed, transparent after-action reviews to understand how to streamline the approval process for the Omicron-specific booster that I'm sure is coming, and unfortunately the next pandemic, without sacrificing the rigor I saw firsthand in the Pfizer trial. There has been much sacrifice to get here, from health workers, trial families, the hundreds of children who have died from COVID, and the countless children and families that may never be the same. We must honor these sacrifices by approving both applications while acknowledging we can never leave our children behind again. Thank you.
Thank you. The next speaker is Laurennnington. You have 3 minutes.
Good afternoon. My name is Laurennnington. I work in global public health, and I'm the parent of 2 children under 5 in Washington State. I have no conflicts. My comment today is broadly in support of emergency use authorization for both the Moderna and Pfizer vaccines for children under 5. Just last week, my kids had yet another COVID-19 exposure at daycare. The toddler came home with a fever, and I felt my stomach knot up. We had COVID in December, and I kept asking, what's the impact going to be of a repeat COVID infection in my unvaccinated child? In May, my friend's 4-year-old was hospitalized due to COVID-19. I asked that parent what she'd like me to say to the FDA on her behalf. Her response was, my daughter was not yet eligible for a vaccine, and public health protections like masking had ended. A vaccine could have offered my daughter protection and prevented a 4-night hospital stay. I remain concerned about COVID-19 and its sequelae, and I want more tools in my toolbox to protect my kids, especially my toddler who cannot mask safely. We've seen increased incidence of diabetes, multisystem inflammatory syndrome, myocarditis, brain fog, and even potentially hepatitis in kids with a history of COVID-19 infection. We know that these mRNA vaccines are safe and effective. 9 million kids over 5 have received an mRNA COVID vaccine in the United States, and in Germany, tens of thousands of under 5s have been safely vaccinated off-label. It's been a long, anxious, and frustrating wait, especially knowing now that the FDA has had Moderna data to review since April. I cannot know the FDA's inner workings, but I can say that the lack of transparency as to why the Moderna under 5 review has taken longer than any other age cohort has made me feel like vaccinating my kids was not a priority for the FDA. But I'm grateful that we're finally here, and I have some important requests about how we move forward. First, please approve both vaccines. The data shows that we have 2 effective options for our kids, and families deserve a choice based on their circumstances. We know that boosters and a Moderna 3rd dose are likely to come in the future, but as the parent of a child starting kindergarten at the end of summer, I would like the option of the 6-week Moderna series that shows superior immunobridging after 2 doses to give my child the best protection as she begins the school year. This shorter series also reduces the burden on families who use public transit or have to take time off work to get kids vaccinated. The 13-week Pfizer series will leave incoming kindergartners with less protection when school starts. I also want to emphasize access. I'd like to see emergency authorization for pharmacists to be able to vaccinate children under age 3. Enabling pharmacies to vaccinate our youngest would reduce the bottlenecks at pediatric clinics, where providers will now have to accommodate vaccination on top of a regular patient workload. And finally, I want to mention boosters. Looking ahead, our youngest kids must get on the same track as adults with access to updated boosters that protect against new COVID-19 variants. Delays with EUA, vaccine access, and boosters have real-life consequences for our families. Every single day matters for our kids. Thank you, and please approve these vaccines for under 5.
Thank you. The next speaker is Kathleen Heinsley.
I have no conflicts. Hello, everyone. I'm Kathleen Heinsley with Friends of the Constitution. Today I'll be presenting some facts for your consideration, but I want you to know that I fully understand how hard it is for you to be in your position and being literally inundated with facts. Everyone wants to do the right thing, but what is the right thing? That's a question that can be mind-boggling at best. I'm hoping that what I say today will relieve some of the stress and fill you with a clear and peaceful understanding of the truth. And now for the promised facts. The FDA is legally prohibited from approving any biological product for emergency use unless all of the following conditions are met. There must be an emergency that poses a risk of death to the target group. The product must be effective in preventing the disease. It must be safe, and finally, the benefits must outweigh the risks. With regard to the first point, children without comorbidities who acquire COVID-19 have a 99.98% survival rate. There is no emergency. Moving forward to effectiveness, a study by Kyle A. Biddy, which includes a data analysis of 145 countries, found that COVID-19 vaccines were, in fact, associated with a 38% increase in COVID cases and a 31% increase in deaths. Could these vaccines be negatively affecting immunity? The number of severe adverse events affecting children ages 5 to 17 reported to VAERS as of June 3rd was 8,811, including 114 deaths and 1,346 cases of myocarditis, a condition that can be fatal. We can assume that if these vaccines are authorized, some babies will die. The benefits of these vaccines are questionable and the risks are clear. Think about your personal priorities, your concerns for your reputation, your job, the approval of family and friends, and issues concerning the financial security of you and your loved ones, as well as your private thoughts about some of the information you have reviewed. These concerns do matter, but there is something that matters more. If these vaccines are authorized, some babies will die. If you were alone and saw a baby of 6 months old right in front of you, would you yourself take a loaded firearm and kill that child? My guess is the answer would be no. And yet, if you participate in authorizing these dangerous injections for this age group, you in fact will be doing that. How would you feel about that at the end of your life when none of the other things matter? How would your soul feel? That's all you need to ask yourself when making the right decision. Thank you very much.
Thank you. The next speaker is Melissa Braven. You have 3 minutes.
My name is Melissa Braven. I'm a pediatrician and a mother. I have no conflicts. I implore you to recommend EUA of the Moderna vaccine presented today. Personal freedom arguments have led to removal of nearly all mitigations, effectively forcing parents to choose between safeguarding their children and participating in society. Under 2s can't mask. 2 to 4s don't mask well. We must provide parents the choice to vaccinate their children when benefits so clearly exceed risks. Moderna's vaccine offers similar efficacy against symptomatic Omicron in young children as is afforded to adults, and this is so much better than nothing. We can expect Moderna's booster will further improve protection in young children, and I'm thrilled these studies are underway. Crucially, Moderna's current mRNA vaccine continues to offer robust protection against severe Omicron disease in adults, and we have every reason to expect the same will hold true for young children. And it will provide proven protection before the new school year begins. This vaccine is also incredibly safe by the FDA's usual rigorous standards, which is fantastic. Thank goodness we are finally here. But this day is bittersweet. The FDA must adapt its approach so that young children's access to updated vaccines and therapeutics doesn't continually lag 18 months behind adults. It's for this very purpose of strengthening the nation's public health protection during a public health emergency that EUA exists. Yet there was no appearance of urgency with respect to our youngest. The long wait endured due both to conventional pediatric trial designs and to unanticipated delays has been measured by families not in units of time, but rather by extended isolation and excruciating sacrifice, and tragically, by vaccine-preventable disease and disability, and in some cases, death. It has been incredibly offensive to hear this wait trivialized as children died. Evidence-based medicine, as I know it, entails making the best possible decisions based on the available information, not being absolved of the responsibility to take any action at all, while awaiting a perfect body of evidence that requires years to accumulate as lives hang in the balance. In this speech, I ask, first, why were age de-escalation conventions adhered to so strictly during the pandemic? Second, when will the FDA revisit the exaggerated concerns about fever and febrile seizure that have impeded vaccine progress and resulted in Pfizer's vaccine being underdosed? The pathophysiology, that is, the science, doesn't support fever phobia. Third, why was the review of Moderna's data delayed? These decisions had profound implications for parents and children who are still waiting, suspended in time 18 months after the members of this committee became vaccine eligible. In sum, how will the FDA evolve so that children's lives are spared? Who among you will champion this change? I am pleading with the FDA to prioritize actual children's lives over an unattainable, unimpeachable abstraction of perfect medicine. Please approve Moderna's life-saving vaccine, and please don't put children in this position again. The FDA must adapt if it hopes to maintain the trust and respect of pro-science parents. We simply cannot let any more children die or suffer unnecessarily and still hold our heads high as physicians or as a nation. Thank you.
The next speaker is Congressman Louis Gohmert. You have 3 minutes.
Yes, thank you very much. There are many unanswered questions regarding the safety and efficacy of COVID vaccines, especially for babies and young children. I'm deeply concerned that the push to vaccinate these children is nothing more than a dystopian experiment with unknown consequences. Some of us have outlined these questions in a letter to VRPAC, but have not received any answers, and I'll post some of them here. The letter's at my website, gohmert.house.gov, and my Twitter account, @RepLouisGohmert. But number one, why has the FDA refused to release the hundreds of thousands of pages of data from pre-approval manufacturer studies, post-approval adverse events data, and other post-approval manufacturer data? Number two, what is the cardiac risk factor in administering these COVID vaccines to children? Number three, would world-renowned immunologists have raised concerns about potential antibody-dependent enhancement, ADE, resulting from COVID vaccines? And since ADE was a problem in prior unrelated respiratory vaccine trials, we need to know what studies, if any, the FDA has that it's used regarding potential ADE from COVID vaccines in children 5 and under, or any age group. Can the FDA affirm that there's no risk of ADE for vaccinated children? Number four, if approved and widely used among children 5 and under, how many lives, if any, does FDA estimate will be saved next year? Given the injuries reported in the FDA's VAERS system, how will FDA evaluate serious vaccine injuries versus serious COVID outcomes? Number five, is it possible that the proposed COVID vaccines in young children would create increased risk from future novel COVID variants? Number six, why has the FDA recently lowered the efficacy bar for COVID vaccines for youngest children? This change significantly lowers the expected benefits from any COVID vaccination for young children, and it's of particular concern given that over 70% of that age cohort are already seropositive. These questions and others are critical and deserve thorough answers by FDA and VRPAC prior to any emergency use authorization with the accompanying protection from liability for all harm done. In conclusion, some of us have grave concerns that in balancing the risks to rewards here, all the risks are to the innocent children and all the billions of dollars of rewards go to the government-protected pharmaceuticals, leaving me to wonder if Republicans get a majority, may need to have a bill, I'm working on it now, to allow civil and criminal liability to vaccine providers and accessories despite an EUA, which should force more sensitivity to vaccine harm to our young children. We've got to care more about the children, and I appreciate the time to express this.
Thank you. The next speaker is Dr. Heishie Klein. You have 3 minutes, sir.
Thank you for allowing me to speak. I'm Heishie Klein. I have no conflicts. In his letter to you of June 10th, RFK said, and you have all the details, so I'll just mention the main points. There is no COVID emergency for children. That's number one. Number two, the vaccines do not prevent transmission. They do not prevent infection. Number 6, the Pfizer clinical trial for children 2 through 4 years old failed to meet the FDA specified requirements for COVID vaccine EUAs. They're proposing to use a product and a schedule that failed FDA's established criteria in its clinical trials. On page 117 of Moderna's submission, they hid their clinical data and instead used a computer model, a simulation, where they adjusted the parameters to give them the results they wanted. And on page 118, they say the risk of myocarditis was assessed using a 7-day risk window. A 7-day risk window after Spikevax injection. How's that for long-term study? Pfizer claims that they did a study of 4,526 participants 6 months through 4 years old. This, of course, is a lie. Like Moderna, Pfizer found ways to whittle down the numbers of participants to force the data to fit a predetermined fictional narrative. Pfizer has a unique problem, and this may be one reason why it has taken them so long to get to the application stage. After Pfizer thought that this clinical trial on kids was going to work, so they unblinded it on September 28, 2021, and they started vaccinating the placebo group to destroy the control and eliminate any long-term safety data on November 3rd, 2021. Then in early December, the data showed that the trial had failed. So Pfizer had to scramble to enroll even more kids in the attempt to save the clinical trial with a third dose. The results then becomes a complete muddle because Pfizer had to refer to the blinded period before September 28th, the unblinded crossover period after September 28th, and then the post-protocol amended 6th period, February 1 to data cutoff of April 29. I pray that you realize that if you choose to ignore the obvious that Moderna and Pfizer are lying, then you'll be doing a great disservice to humanity. You know that, and you know that all it takes is for evil to win, is for good people to say nothing. If you remain silent and do not call them on their lies, you're allowing Moderna and Pfizer to lie to the American public, and at what cost to human lives? In the Purim story, the evil Haman wanted to kill all the Jews. Mordecai said to Queen Esther, "Do not think you'll be able to escape in the king's palace any more than the rest of the Jews. For if you persist in keeping silent at a time like this, relief and deliverance will come to the Jews from some other place, and you and your father's house will perish." And who knows if it was for just such a time as this that you attained the royal position. We are at a cosmic turning point in the history of the world. We are in a war between good and evil. And who knows if it was for just such a time as this that you attained your positions on the VRBPAC. You have a once-in-a-lifetime opportunity to do the right thing for humanity and for God, and you will be remembered in the history books for eternity. I pray for you that you look in your hearts and souls and find the courage to stand up to Big Pharma, like Esther stood up to Haman and saved all the Jews. You have the opportunity to save humanity and the world. Pfizer and Moderna have not met requirements and should not approve. You know that. Stand up against them on the side of God, on the side of good, and may God smile on you always and in all ways.
The next speaker is Kelly Solar. You have 3 minutes.
Hello, my name is Dr. Kaylee Stoller. I'm a PhD chemist, and I have no conflicts at all today. Thank you so much for the opportunity to speak today. And I'm a PhD chemist, but even more importantly, I'm a mom of an under 2-year-old. I spoke emotionally yesterday on all the reasons why parents are desperate to vaccinate their children under 5. Today, I'm here to speak very scientifically and logically to ask you to make the only logical decision available, which is to approve both the Pfizer and Moderna vaccines for this youngest age group based on 3 points. Number 1, these vaccines, first and foremost, have been proven to be safe. Number 2, these vaccines are effective. And number 3, authorizing these vaccines gives all parents the ability to make the choice that they deem best for their family. Regarding points 1 and 2, these vaccines are safe and effective. For all other age groups, when the vaccines have been proven to be safe and effective, we have approved, after careful scientific review and without hesitation, we have authorized the vaccine. I would like to thank the sponsors as well as the FDA, CDC, and the ad hoc members for all of their dedication to a rigorous and complete scientific review and presentation of the data. It is very clear from the data that these vaccines are safe, and the benefit of vaccination helps decrease the risks associated with COVID infection. Beyond prevention of symptomatic infection, in addition, there's additional benefit of the cellular responses which help prepare the immune system and the body to fight off future infection. This is harder to measure, but can be logically and scientifically inferred by the multitude of data that we have from older age cohorts and our knowledge of how vaccination and immunity work in general. Regarding point 3 and allowing parents a choice, Authorizing these vaccines gives all parents access to either choice that they desire to make for their children. For parents without access to the choice that we desire, which would be to vaccinate our children, we are desperate for this choice. The pandemic has moved into a personal risk-benefit analysis stage where we are encouraging individuals to self-assess their risk and make decisions about their own health. Parents who assess that the risk-benefit of these vaccines versus COVID infections have two choices to consider, as it is clear that COVID infection will likely become inevitable. Number one, their child could get COVID without having been vaccinated, or number two, their child could get COVID with having been vaccinated. However, only one of these options today is available to parents under 5. However, my choice from these two options would be number 2, to vaccinate my child, which is not available to me today. However, today we have the logical option, which is based on the scientific evidence that has been amassed, indicating that both of these vaccines are safe and effective, and we need to allow access to both of these risk-based decision options for parents and authorize both of these vaccines. I will vaccinate my daughter as soon as possible. I don't want a vaccine mandate. I don't want to force other parents to do the same, but I want the choice, and I'm asking for that choice that I desire to make. For parents who choose option 1, decisions made today on authorization would not have to change that choice. But for me and many others, the decision without the authorization of these vaccines would be absolutely life-changing. I urge you to make the most logical and fact-based decision today. Allow us this decision to vaccinate our children and empower us as parents to protect our children. Thank you so much for your time today, and thank you so much for your dedication to the scientific process.
Thank you. The next speaker is Shailene. You have 3 minutes.
Good afternoon. I'm Shay, and I have no financial involvement in this discussion. I am a mother, former educator, director, and recently worked as a tech manager developing startups in the health space. I was never exposed to COVID-19. My children have also been enrolled in private schools with 0 exposures. Please recall these products immediately. Do not harm our low-risk children. They do not need myocarditis from long-haul COVID vaccine adverse reactions. We demand informed consent. As a parent, I wanted to do the right thing to protect my children against COVID-19. So I received the first dose of Pfizer on April 3rd. Little did I know this would be the worst day of my life. After an hour, I called 911 due to an anaphylactic reaction. I never experienced anything like this in my entire life. My heart was racing. I felt so weak, disoriented, and vertigo, almost like I was going to faint. I had severe chest pains. I couldn't breathe due to throat closure sensations. I felt feverish, but I was fine just an hour ago. My family was present, but they didn't know what to do. We just wanted to do the right thing. We were informed the vaccine would be safe, as our entire family and friends were all vaccinated. But I felt completely betrayed and lied to. I had no other choice but to call 911 for help after my Pfizer vaccine. I was asked to stay on the phone until paramedics arrived to make sure I did not faint. I honestly thought I was dying, and I wasn't sure if I was having a heart attack. I've always been incredibly healthy and in excellent shape. I felt like my entire life flashed before my eyes. My vision was very blurry, and I couldn't stop shaking. I'm still shaking right now, 14 months later. The paramedics finally arrived and advised me to take Benadryl, and I should be admitted into the ER right away. They assured me they would not let me die, but I realized they didn't know about adverse reactions. It seemed like no one was really prepared to deal with allergic reactions. It almost seemed like a drug overdose. I wouldn't really know since I never take medication, nor do I drink alcohol. At the ER, I was only monitored and prescribed an EpiPen, then discharged immediately. The doctor didn't feel the need to do any further testing, so I received no explanation other than I had an allergic reaction. I left feeling confused, and I still didn't feel well. And now I had to prepare to deal with allergic reactions when I never had any severe allergies prior. I only had a minor rash as a child due to amoxicillin. Prior to leaving the ER, I remember the ER doctor being slightly confused and clearly stated, only elderly people die from these issues. I was surprised he would even admit to that, considering my elderly relatives were just vaccinated. I felt so alone, so lost, so confused with no answers. I felt dizzy. My vision was affected. I had to take Benadryl and Tylenol for a week straight. They wouldn't prescribe anything else for me. They didn't think this was going to be long-term. I contacted my doctor almost daily. My heart felt weird. It felt like flutters. I wrote emails for answers to my doctor. No one knew anything. I felt like I was being completely ignored and my symptoms were dismissed. My doctor denied referrals to cardiology, neurology, and denied me of an MRI. I kept calling and hoping to get new doctors on call for answers through urgent care and Zoom visits. One doctor eventually prescribed me blood pressure medication for palpitations. It was propranolol. Did she realize I'm breastfeeding? I had the worst nightmares and ringing in my ears. I couldn't sleep. I was afraid I would never wake up again. My doctor,
your time is up. Please, can you wrap it up?
My doctor advised me to purchase blood pressure monitor and track my blood pressure daily. It was really high. I never experienced this issue prior. I also had internal tremors, very similar to Parkinson's. My legs were weak and felt numb. I kept thinking I'm too young to develop Parkinson's or become paralyzed. After 2 weeks of being on the heart monitor, I quit taking my medication as side effects stated and may cause heart failure. I was still breastfeeding, and I'm worried that my child will experience long-term issues from these vaccines and adverse reactions and affect his development. He's now under evaluation and may need to see...
Ma'am, you have to stop. We have to move on. I apologize. All right, next speaker.
Okay, next is Kate Schenk. You have 3 minutes.
Good afternoon. Thank you for allowing me the opportunity to speak today. My name is Kate Schenk. I have no conflicts. I'm the mother of 3 children, ages 4 years, 2 years, and 7 months. Since the beginning of the pandemic, my husband and I have done everything we can to protect our children from COVID-19. Our children haven't been inside grocery stores or department stores, let alone typical childhood staples like indoor amusement parks, museums, malls, and restaurants. I am thankful that my children have remained healthy, but it's been a long 2 years. Last year, I was pregnant with my 3rd child, who was due in November 2021. After my husband and I received our COVID vaccines as soon as they were available to us, it seemed hopeful that a pediatric vaccine would likely be coming in the fall, around the time the new baby was due. I imagine we would still have to be careful for the baby's first 6 months until he was old enough to be vaccinated himself, but at least the risk would be somewhat mitigated since everyone else in the family would be vaccinated. As we all know, that pediatric vaccine didn't come last fall or in February or in April. That baby is now 7 months old, and still none of my children are able to be vaccinated. My oldest child would be 5 years old in mid-August. She is supposed to start kindergarten on September 1st. Because of the pandemic, she has stayed home with me instead of attending preschool. She is so very excited for kindergarten. She is eager to learn and play with kids her own age. Because of her late birthday, the only way she'll be fully vaccinated before kindergarten starts is if the under 5 vaccine is approved now, particularly Moderna, since it's a shorter series. Moderna would allow children starting preschool and kindergarten this fall to reach the same protection and antibody level in only 2 doses compared to Pfizer's 3-dose series, which instead produces similar efficacy and immunobridging over a period of 3 months. Boosters for each could be considered in the future, making Moderna 3 doses and eventually Pfizer 4. I urge you to please act now to authorize emergency use of both Moderna and Pfizer vaccines for children under age 5. At this point in the pandemic, many people have seemingly moved on and are completely forgoing COVID precautions such as masking and social distancing. And our youngest children have been left behind, unprotected. Those without children do not even recognize the toll this has taken on young families, since we have become invisible while they are living life as normal. Please allow parents to give their children the layer of protection that vaccination allows. The data indicates that these vaccines are safe and have met immunobridging. They can protect against the most severe outcomes, the things that have kept parents awake at night since the beginning of the pandemic, death and hospitalization, and can potentially decrease the risk of other complications like long COVID, MIS-C, neurological effects, diabetes, and hepatitis. We need to protect our children without further delay. Thank you for your time.
Thank you. The next speaker is Tamara Thompson. You have 3 minutes.
Good afternoon, members of the committee, and thank you for allowing me to address you again today. I have no financial conflicts. My name is Tamara Thompson, and I am an attorney who represents children as well as the mother of a 5-year-old boy and 23-month-old girl.
Yesterday, I urged you to recommend authorization of Moderna for the older pediatric cohort, and I'm thankful that you did. I also urged you yesterday to do the same for the youngest cohorts. I am here again today to request that you vote to authorize both Moderna and Pfizer for the youngest age group so that our littlest Americans can have access to these life-saving and necessary measures of protection against severe outcomes, disease, and death from COVID-19. I spoke yesterday about how important this authorization is to me and my family and how long we've waited to protect our sweet girl. She is actually one of the data points you saw in Moderna's presentation today as we joined the trial in February. Today, I want to address how important it is that both vaccines are authorized for other families. In my social circle, I have heard from many other parents that they are desperate to vaccinate their children under 5. They thank me for my advocacy and tell me how exhausted they are and how very hard it has been to feel left behind and with no measures to protect their young children from the threat of COVID-19, referring to both the acute threat and the possible long-term harm of infection after infection with SARS-CoV-2. Long COVID is a threat to children and adults alike. Like me, other parents have pulled kids from daycare during surges and worked their full-time jobs from home while trying to parent babies and toddlers. They've also gone through interruption after interruption of care with illnesses, exposures, quarantine, and isolation. Some parents are not able to work from home at all and don't have the ability to pull kids during surges, but must take unpaid time off when exposures and quarantines occur. I have heard over and over again that it is exhausting, and it's been even more difficult since the rest of the world has moved on, dropping all non-pharmaceutical interventions because they, quote, have all the tools. We don't have the tools, not for our little ones, and therefore not for our families. It is essential to authorize both vaccines right now because there are advantages to each series that will help families in different positions. For example, we see greater efficacy in immunobridging in just 2 doses of Moderna versus 2 doses of Pfizer vaccine, which would allow rising kindergartners to achieve more protection before starting school in September. At the same time, while Pfizer's N in calculating efficacy is low and confidence interval wide, it may be that its 3-dose scheme provides greater efficacy in the long term. In addition, having 2 vaccines for this age group available will help in ensuring better access, a stronger supply chain, and a choice for families who have waited so long for protection. We need options, we need access, and we need to make sure this group catches up to older cohorts in terms of variant-specific boosters and up-to-date preventatives and treatments. As we heard Dr. Fauci say in April of this year, all of the stuff you hear about kids, let them get infected, is a bunch of nonsense. Please authorize both the Moderna and Pfizer vaccines for them today. Thank you for your time and dedication to the scientific process.
Thank you. The next speaker is Mr. Sam Dodson. You have 3 minutes, please.
Hello, my name is Sam Dodson. I run a podcast called To the Lifeboats, and I have no relationship with the pharmaceutical cartels. I'm schooled in electrical engineering, and 2 years ago, I'd never heard of mRNA, but let me tell you what I've learned since. It starts with the shot you told us stays at the injection site. We know it doesn't. You knew it didn't. Biodistribution studies show that it goes to every major organ, primarily the heart, liver, and spleen, where thanks to the highly inflammatory lipid nanocomplex, it transfects the cells. That complex contains a pegylated lipid being mass injected into humans for the first time ever, while the animal studies showed heart attacks in pigs after the second injection. You knew the lipid nanocomplexes collect in the ovaries, where they have the potential to cause devastating effects on reproductive health, yet you did nothing. When women started complaining of menstrual problems, you did nothing. Transfected cells in every organ pump out the spike protein that ends up in the nucleus where it interrupts p53, line 1, and BRCA. You didn't know this because you didn't care to ask the question. And when shown to you in a study, you did nothing. Every transfected cell expressing spike protein risks autoimmune disease, the most acute of which is myocarditis. When people started dying of myocarditis, you did nothing. The spike protein floats freely in the vasculature, finding its way into the brain, breast milk, and the environment as the body sheds this protein in exosomes, making those around the vaccinated sick. The spike protein directly affects toll-like receptors and CD4 T cells, which are essential to the immune defense against these very viruses. When the vaccinated repeatedly caught COVID and suffered reactivation of herpes, shingles, papillomavirus in unprecedented numbers, you knew this was a massive problem, yet you did nothing. You knew that the mRNA stays around for months in lymph node germinal centers, causing T-cell exhaustion, because the Stanford group performed the study that you couldn't be bothered to do. And then you ignored that massive safety signal. You were warned about oncomers and the effect on P53, yet you did nothing. When you were warned about prion disease and amyloid as a result of the huge amounts of spike protein produced by these therapies, you did worse than nothing. You silenced those people who raised the alarms. You were informed of fraud in the vaccine studies, yet instead of investigating, you colluded with the manufacturers to suppress trial data for 75 years. Knowing all of these concerns, you now want to inject the very young who have zero clinical risk from COVID and for which not one single study has shown any clinical benefit. You have abjectly failed in your sole duty to ensure the safety of any drug given to Americans. The late Francis Oldham Keesley would have been ashamed at how you've turned a once respected agency into a corrupted vessel for the very corporations you swore to protect the American public from. If you have one shred of humanity left, you will recommend an immediate halt to all the shots and pray that God has mercy on your souls. Might also want to figure out how we're going to diagnose myocarditis in very young babies who are unable to speak. Thank you.
Thank you. The next speaker is Donna. You have 3 minutes.
Hi. Thank you. My name is Donna. I'm grandma to 2-year-old Liam and a licensed family daycare center owner-operator. I have no conflicts. Please take a moment to picture your life right now if you weren't given access to even one COVID vaccine dose yet, 2.5 years after this began. Now think about going into a small room with 20 other unmasked, unvaccinated people, eating and napping in close contact, spending up to 10 hours there every weekday. This is the scenario parents are forced to put their unvaccinated children in every day, and is why I implore you to approve a vaccine for children under 5 today. COVID seeks out those who are unvaccinated. The convoluted path to approval these trials have taken have left the youngest of our society most vulnerable. The repeated reassurance that a vaccine would be available in the coming weeks or months has not brought hope to families, but rather frustration and despair when these claims did not come to fruition. The truth is, families have gone to extreme lengths to protect their babies because children are getting very sick and dying of COVID-19. The FDA should strive to be nimble and able to pivot quickly as the virus changes. If the rest of our country can choose a vaccination and subsequently drop any and all mitigation measures before all vulnerable populations have protection, then parents deserve the right to choose to vaccinate our children and to choose between Moderna and Pfizer. We need a comprehensive plan to ensure this age group has access to up-to-date boosters and future variant-specific vaccines at the same pace as all other age groups. Our governmental bodies need to do what is necessary to ensure our children are not denied life-saving vaccines for 2.5 years during the next pandemic. When you cast your vote this afternoon, please remember these small children and vote to approve both Moderna and Pfizer vaccines for children under 5 so that they have some protection with reduced risk of severe illness caused by COVID-19. Thank you for your hard work throughout this pandemic and for giving me the opportunity to share my views.
Thank you. The next speaker is Catherine Deal.
Good afternoon. My name is Catherine Deal. I'm a mother of 2-year-old twins and a PhD in philosophy with a focus in medical ethics. I have no financial conflicts. I'm here today to strongly urge the committee to recommend authorization for both vaccines. The question before you for each vaccine is whether, based on the totality of medical information available, its benefits outweigh its risks. The data presented today and real-world information collected over the past 2 years demonstrate that the answer to this question is a clear and resounding yes. To evaluate the benefits, we must follow the standard of probable improvement, employing the tools of Bayesian analysis supported by the FDA's own guidelines. These vaccines very clearly meet this standard. We are better off with them than without them. This standard must guide our action rather than any arbitrary statistical cutoff, such as a requirement of 50% efficacy against symptomatic illness. Such a standard would be additionally inappropriate in the context of current variants, when attention has shifted to protection against severe outcomes, including hospitalization and death. Evaluation of these vaccines does not occur in a vacuum. Rather, it occurs in a context in which these vaccines have proved to be safe and effective in adults, as well as in a slightly older age cohort. This background should inform our priors, that is, our starting point in our considerations here. The success of both trials in meeting immunobridging without any safety signals allows us to update these priors in light of positive evidence. Following the standard of probable improvement lets us infer from successful immunobridging that it's highly likely the vaccine will be similarly effective in the prevention of severe outcomes like hospitalization and death in children under 5. The safety record in older cohorts and absence of safety signals in the trials also reassures us that new safety issues are not likely to crop up once vaccine distribution commences to the broader population. You have seen compelling evidence in both companies' documentation that the benefit-risk analysis is favorable based on acute outcomes, but there are additional factors that speak in favor of approval. COVID infection carries substantial long-term risks. Our understanding of these long-term implications is ever evolving, and it's here that the methodology I have described is particularly helpful. To ignore the growing evidence of lasting cardiovascular damage, new type 1 diabetes diagnoses, brain atrophy, vascular amyloid deposition, hepatitis, and so on, merely because we have yet to accumulate a decade's worth of high-quality, double-blinded, randomized control trials and meta-analyses thereof would be dangerous and irresponsible. These vaccines are likely to reduce such effects in 2 ways. First, by preventing some portion of infections, they reduce the number of cases in which long-term damage can occur. Second, numerous studies have suggested that breakthrough infections are less likely to lead to long COVID. Again, this must be factored into our analysis. As a philosopher and a parent, I urge you to approach your decision with these methodological principles in mind and reach the conclusion that both vaccines should be approved. Thank you for your consideration, and thank you to the families in these trials who have made this possible.
Thank you. The next speaker is Jessica Neri.
Good afternoon. Good afternoon. I have no financial conflicts of interest. I am a mother of 2 amazing children. My daughter is 6 and my son is 3. I am speaking today to advocate for children under 5 years old and their parents who wish to have the option of vaccinating these youngest children. Since most masking mitigations have been lifted, children under 5 have been sitting ducks for COVID without protection, while vaccination has been enthusiastically recommended to every other age group. We have been through 6 waves of COVID now, including the current surge, with no protection for our most vulnerable children. The children 3 and over that can mask are obviously not wonderful at it, and the children under 3 have absolutely nothing at this point to protect them from severe and sometimes fatal outcomes. Based on real-world data in persons 5 and above, it can be safely concluded that Moderna and Pfizer's vaccines for our youngest children offer excellent protection from hospitalization, severe illness, and death. I am frustrated that this process was stalled with Moderna since their studies were nearly complete in December when an expansion was requested by the FDA. Parents still long for a clear explanation regarding the reason for this expansion, which was requested during the largest COVID surge of the pandemic, one that resulted in thousands of children under 5 hospitalized. It is upsetting that a safe and effective vaccine has not been prioritized, especially with so many Americans getting back to their normal lives, resulting in our children being placed at even higher risk of infection. In the past 2 years, my husband has worked in nursing homes, schools, restaurants, and churches as a union HVAC service tech. He has chronic asthma and has been wearing a mask for years at this point, just to protect himself and our family until we can all be vaccinated. I have put off doctor's appointments these past 2 years for a pre-pandemic health issue because of the fear of bringing the virus home to my son and daughter before they have been vaccinated. Parents like myself are frustrated that we are not being seen. We believe in science and the process of trials, evaluating data, and the health agencies involved in managing all of these aspects. But moving forward, I would hope this age group doesn't get left behind again. I would like serious thought given to the possibility of running trials for future treatments and vaccines of all age groups at the same time so our youngest children are not forgotten. Relevant agencies need to work with state and local governments to facilitate a rollout that's truly fair and equitable for all kids under 5 and their parents. Parents like myself just want the choice. Thank you for giving me the time to speak.
Thank you. The next speaker is Kathleen Lindy. You have 3 minutes.
Thank you for this opportunity. My name is Dr. Kathleen Heinsley. I'm the member of the Steering Committee of the World Council for Health. I have no conflicts of interest. CDC data from February show that about 74.2% of children have had COVID already. Over 150 studies show that natural immunity is superior. The infection fatality rate under 5 years of age is 0.1 in 100,000 or 1 in a million. The risk of the shot in the already immune is higher than 1 in a million. Both Pfizer and Moderna expressly eliminated those that were naturally immune from their studies. They did this to avoid the hyperimmune response and possibly death. Vaccinating the already immune puts them at serious risk for having a hyperimmune response. That means you will be voting for some children to have a severe adverse reaction and possibly death if you vaccinate the already immune. This is bad medicine. There is zero reward, only risk. These vaccines are not medically necessary or clinically indicated. Bayers show children ages birth to 18 who have been vaccinated with Pfizer and Moderna's vaccine have had severe life-threatening adverse reactions such as myocarditis, Guillain-Barré, seizures, and more severe adverse reactions of death. Article by House and all that was published in May 22 of 2022 in American Academy of Pediatrics shows myocarditis 2.2 per million cases, seizures 7.6 per million cases. I will share 2 cases seen by my colleagues. 14-year-old male double vaccinated with Pfizer vaccine has recent history of chest pain on exertion. Initial echo and EKG were normal. Troponins 22,000 increasing to 48,000 in 6 hours. Cardiac MRI with gadolinium showed transmural enhancement consistent with myocarditis. Case number 2, 13-year-old female, first Pfizer dose last August, had first seizure within 30 days. Got a second vaccine in December, had another seizure, then had a third booster and now has 4 to 6 seizures a day. She was an active soccer player and a good student, now unable to play sports or attend class in person. We have no long-term safety data in any of these studies. The risks clearly outweigh the benefits. The VAERS reports 28,312 deaths so far in all age groups. When will we say this is enough? What is the magic number that will make a cutoff and stop pushing these vaccines? Is it 50,000, 100,000, million? When do we say that we cannot give this to our children? Their recovery rate is over 99.995%. These are healthy children, and the risk does not outweigh the benefits. These vaccines are not medically necessary or clinically indicated. No, thank you for your time.
Thank you. The last speaker for the session is Caroline Bishop. You have 3 minutes.
Hi, thank you. My name is Dr. Caroline Bishop, and I'm an associate professor of classics at Texas Tech University. I have no financial conflicts of interest. I'm here in my capacity not as a professor, but as a mother to urge you to approve both the Moderna and Pfizer vaccines for children under 5. Today, I wish to share with you the increasingly punishing lengths I've had to go to in order to keep myself and my 14-month-old daughter free from COVID as we've continued to wait for a vaccine. I could talk about the difficult decisions we've been forced to make along the way, canceling our daycare during the Delta wave and keeping my daughter at home with me while I was technically on a Harvard-funded research sabbatical to write my second book, never having gotten to take her to a museum or to visit her cousins or to a play date, being able to count the time she's been in the grocery store on one hand. But instead, I'm going to focus on the fact that I've had to be a solo parent for the past month or so, watching my daughter full-time, never leaving the house, while also feverishly writing a conference paper that I have to deliver this Friday during naps and after bedtime has been one of the most challenging experiences of my life.
Why have I been doing this? Because my husband, who's a trial attorney, can no longer wear a mask in court, part and parcel of the countrywide removal of all mitigations at a time when we're seeing one of the worst COVID surges yet. As cases began to grow in our area, he made the heartbreaking decision to move out to our guest house. At the time, we'd hoped the committee might meet to approve the Moderna vaccine on June 8th, and when the meeting got scheduled for today, our hearts broke a little more. This past month, I've been desperately holding on for my daughter to have the protection against severe outcomes that both the Moderna and Pfizer vaccines have been shown to provide. I've been lonely and alone, devastated when my husband missed our daughter's first steps. I know he feels devastated too. He has to hear her call out Dada when she sees him in the yard and know he can't cuddle and play with her. She's always so delighted to see him and doesn't understand why he won't horse around with her like he used to do. We didn't publicize this decision of ours. Only a few close friends know. That's because even among our highly educated friend group, almost everyone is acting like the pandemic is over. I spoke to you yesterday about the special kind of heartbreak you feel when you see people you love, like, and respect start to act with absolutely no concern about the fact that your child has no protection against COVID. Today, I'd just add that it's both disorienting and maddening to see almost everyone living like it's 2019 again when you're still stuck in March 2020. However, I can now say with certainty that my husband and I made the right decision, hard as it might have been. How do I know? Because this past Friday, he came home from work with a sore throat, and as I'm speaking to you, he's sick with COVID. Fortunately, he's vaccinated and boosted with Moderna, and his case has been mild. My daughter deserves that same protection. You have the ability to give it to her and to reunite our family. For myself and for the many parents who didn't have the privilege to isolate like I have done, I'm begging you to approve these vaccines. Thank you very much.
Thank you. That completes the open public hearing session, and I would like to hand over the meeting back to our chair, Dr. Monto. Take it away for the next session, next item on the agenda.
Thank you, Prava, and I thank all the participants in the open public hearing. We really do listen to what you have to say to us. We now return to the question and answer sessions. We will first deal with the question and answers about the Moderna vaccine. And these questions can be for the FDA presenters or the sponsor presenters. We have a relatively short period for the question and answer sessions, 25 minutes, after which we have our own internal discussion. So remember, there's that session as well. And following that, the vote, completing the action on the Moderna vaccine. So we're completing the action on the Moderna vaccine. Okay. Doctor, let me see if I've got the full list in front of me here. Dr. Berger, followed by Dr. Perga.
Hi, thank you all for the earlier presentations. I had a question based on FDA's briefing document that was supplied, and specifically it was the two tables that looked at the subpopulation analyses, specifically looking at the vaccine efficacy in children who are obese. I noticed that the vaccine efficacy rates for the 6 to 23-month-olds were negative 5.6, and 2 to 5-year-olds were listed at negative 15.4, and fully recognizing that the confidence intervals in these were huge. Just wanted to get a sense of whether, because I didn't see this listed in the in any of the post-approval examinations. What kind of data are you currently collecting on children who are obese to understand the efficacy there, or to at least dive into this signal a little bit more?
So I believe that was a question for me, but if I'm wrong, please correct me. So I think the question is about Moderna and how we follow up on the efficacy rate in children who are obese. And so as you mentioned, we have some efficacy data from the original clinical trial. However, those data right now are a relatively small subgroup of the overall population. And so the way in which we will be moving forward to follow vaccine effectiveness would be actually in the long-term effectiveness study that we have ongoing in Southern California. So in that study, we are able to enroll hundreds of thousands of individuals, and we actually are parsing those analyses by specific risk groups. I can show you the immunogenicity in the young children. So if you can please put up slide IM23 for me.
Oh, give me a second. I gave it to the wrong share. So Moderna, give me 1 second.
No problem.
Actually, Moderna, now you should have the right share right now, unless you want to. Oh, you moved it. There, wait, hold on 1 second and take it away. You got it.
Okay, there we go. And then I'm just going to say that I'll want the slide in a moment for the 6-month to 23-month-olds. So what you see here are the geometric mean titers and associated 95% confidence intervals for the children who were 2 to 5 that received mRNA 1273. And you also see the respective GMT ratios, and this is, again, versus the adult population. I need to note again that the sample size of the children who are obese is relatively will require further follow-up. And then if we can put up the next slide, which is IM24, we'll see the infants and toddlers. And so here we see GMT ratios of 0.9 to 1.4. Again, sample size is relatively small, so wider 95% confidence intervals in those who are obese. But overall, greater than 1,500.
Thank you.
Thank you, Dr. Perkham, followed by Dr. Sawyer.
Thanks. I had a question for the sponsor. I didn't get to ask this question initially when you presented your data. You had a fairly large study population in the phase 1 trial that got the higher dose of the vaccine, and similar to what I asked Pfizer. I'm curious, did you see a dose-dependent response in that higher dose compared to the lower dose that you ended up choosing? And then as a second question to that that's somewhat relevant is, in your post-marketing studies that are planned, there's no discussion of the immunosuppressed population. And as we have seen in post-marketing, immunosuppressed populations have received an extra or a third dose as a primary series. And I'm curious if there are studies planned for Moderna for immunosuppressed children to specifically address this question.
Yep, thank you for that. So what I would like to do is address your first question first, which is the comparison of the 25 microgram and 50 microgram, which are the doses that we investigated in this trial. And so could you please project AA8? Sorry, that's alliteration, but 2 A's and an 8. There you go, thank you. So what you see in this slide is the young children, and you had asked about a dose response. So we do see a dose response with a higher dose, and we saw GMT ratios in the initial Part 1 population of 0.8 and 1.4 respectively. We were also looking at the safety profile at the time, made our recommendation to a data and safety monitoring board, and they in fact confirmed that they agreed with our selection of the 25 microgram dose in the children 2 to 5. And because we selected the 25 microgram dose, then we did not go up to 50 micrograms in the youngest babies. And then your second question for me is with respect to immunocompromised children. And so we have already committed to doing in Europe immunocompromised trial. And in fact, we were waiting until we had selected the dose and had confirmation that that dose was safe and effective in healthy children before moving to the immunocompromised population. And of course, we'll be studying a 3-dose schedule as we're administering to adults with the selected dose.
Thank. Thank you very much. Appreciate that.
Dr. Sawyer, followed by Dr. Kim. Or are we up to, yeah, Dr. Sawyer.
Thank you, Dr. Monto. So it appears that fever is occurring at a significant rate, which is something we see with other routine childhood vaccinations. But the pediatricians in the group have certainly lived through the experience of seeing enhanced fever and even febrile fevers with co-administration of other vaccines together that all cause fever. Dr. Chatterjee brought up this question earlier, and the sponsor replied that they are planning some co-administration studies. My question is for FDA. Are such co-administration studies required for a full BLA, or is it up to the sponsor to just decide how much to study that question, and or do we need to wait for post-marketing or post-authorization studies to really get a handle on that question?
Thank you for that question. Thank you, Dr. Fink. I think you're best ready to handle that.
Thank you. I will answer that. So we have routinely requested co-administration studies in licensure applications of vaccines that are intended for the very young infants. Those who are younger than 6 months of age, because the immunization schedule is so compressed. And it is difficult to avoid co-administration. We have not routinely requested or required co-administration studies for older children, but we have always encouraged vaccine manufacturers to study safety and evaluate for immune interference of co-administration when introducing a new vaccine into the pediatric schedule. And we do expect that studies will be done going forward looking at this.
Thank you.
Thank you.
Dr. Kim, followed by Dr. Gans.
Well, thank you very much. On the topic of primary series and booster dose, I think the committee has discussed this on several occasions. But on that topic for Moderna vaccine, the definition of primary series is 2 dose, and you're currently working on a study to evaluate the impact of the 3rd dose. And it's on that 3rd dose that I'd like to ask you if you have any preliminary information, or if you can share with us some of the characteristics of the study design and the possible impact, and perhaps your hypothesis and how that might influence your definition of primary series versus booster dose.
Yeah, so I'll speak a little bit about the boosting that we're planning in each age cohort. We don't have hypotheses to define 2 versus 3 dose series, but as I mentioned, we've heard your feedback about that. But in terms of the 3rd dose booster, in adolescents, we asked them once we saw the incidence rates climbing after Omicron, as we discussed yesterday. And those data, actually, we are anticipating momentarily, and we'll be sharing them with the FDA once we have them compiled. That will be the first group. Then in July, we will be getting the data from the 6 to 11-year-olds. So the 6 to 11-year-olds were followed primarily through Delta. The longer-term follow-up cohort is now mostly the mRNA 1273 cohort because of the authorization of another vaccine and people going to get vaccinated. So we'll really see just primarily what that 3rd dose booster looks like in that cohort. That will come in July, and of course we'll share those data when available. And then the youngest children, actually, based on other feedback we've received from this committee, we tried to keep the blinding in place as long as possible to have as long of double-blinded efficacy follow-up as we could. I think once a decision is made and 1 or more vaccines hopefully will be authorized, we will be unblinding and then offering that third dose at least 3 months after the second dose. And that 3-month interval is really defined by an interval that we've seen from DMID. So DMID assessed heterologous boosting with that 3-month interval afterwards. And you know, as you mentioned, there may be some safety and immunogenicity benefits to that interval. So we will share those data when available. And then we have mRNA 1273, and we have some clinical supply with an Omicron-containing variant. And so there will be some of the cohorts in the youngest kids receiving the Omicron-containing variant. And that really is to bracket the variant. And so there will be some of the cohorts in the youngest kids receiving the Omicron-containing variant. And that really is to bracket the booster responses. So we'll see the Omicron data that we'll share with you in 2 weeks in the adults. And then in these youngest kids, the Omicron-containing variant. And we believe that will really help give the cumulative picture of the capability of the vaccine.
Thank you very much. A very broad response to a broad question. Dr. Gantz, followed by Dr. Reingold.
Thank you so much, and I really appreciate everything, all the thought that you've put into what you will be doing moving forward. And so my question really for the FDA, and I don't know if Doran Fink is available, but I'm impressed with how much there is after already predicted to be available to the FDA. And my question is, before moving on to licensure, will there be availability of the data to be reviewed by the committee, and maybe even some recommendations moving forward on what is.
Dr. Fink.
Thank you. I think FDA always makes a case-by-case decision on seeking input from the VRBPAC, depending on whether we consider there to be important questions about benefits and risks that would benefit from or require input from the VRBPAC. I think as you know, we have taken certain actions without a VRBPAC meeting when we felt that those actions needed to be done expediently, or when we felt that the very most pertinent issues regarding benefits and risks had already been discussed and there was nothing new to discuss. And so we will consider those factors before we take any future action on a case-by-case basis.
Thank you.
Thank you very much.
My question to Moderna is, are you going to be looking at immune correlates in any of your studies moving forward? Because we seem to be stuck on looking at neutralizing antibodies, which we all know for viruses, while show you some correlate that is there in the immune system is not necessarily the correlate of protection for these respiratory viruses.
Yeah, so this absolutely is an area of interest for us. We have published our work from the ancestral strain, which Dr. Goss discussed a bit with you yesterday. And we're now speaking with our collaborators at the CoVPN and then also at the NIH about now how we might take those results as we're getting the Omicron neutralization titers and Omicron cases and work on an Omicron correlate of protection. So I think our feeling is that probably Omicron is the next most important variant to investigate. And so we're discussing how we might do that now that we're so distant from the original blinded efficacy trial. But it's definitely an area.
Thank you very much. Moving on to Dr. Reingold, followed by Dr. Nelson. And only one question after that. We're falling behind schedule. Dr. Reingold.
Thanks very much. I'll try and make it quick. So first, Mark Sawyer asked my question about co-administration, but the other question I have, for a lot of routine childhood immunizations, there isn't much circulation of the agent in the population, so we're not typically faced with the problem of administering the vaccine to a child who's recently been infected or already has antibodies, and clearly with COVID-19, that's not the case. and you may have shown these data, but in terms of reactogenicity, either with it pre-existing antibody or recent documented COVID-19, is there any reason that the safety profile would be considered different? This presumably will be an issue for CDC if the vaccine is given EUA, what kind of clinical guidance they give about either delaying vaccination or proceeding with vaccination under different circumstances. Thank you.
Yes, we actually do have the safety data by seropositive and seronegative adverse events. So if you can put the slide up, please, it's SY23. Thank you. So what you see on this slide are the children who are 2 to 5 years of age children that were SARS-CoV-2 positive at the start of the study. In black, the ones that were SARS-CoV-2 negative. The rates were relatively comparable between those two subgroups. If there was a trend that we noticed, it was that systemic rates of reaction tended to be higher after post-dose 2 in the initially seronegative children, as opposed to post-dose 1, which was more frequently observed in the seropositive children. And then let's also put up the data for the infants and toddlers. Oh, sorry.
Go ahead,
Dr.
please.
No, I just wanted to show you for the other age group what the data look like post-dose 2 and post-dose 1 for the seropositive and seronegative children. Thank you.
Okay, thank you, Dr. Nelson, followed by Dr. Fuller, who will be the last questioner in this session.
Yeah, so I just had a couple of quick questions. I know we're falling behind. And one has to deal with the subpopulations of blacks who are enrolled in your current study. So I did note the overall low enrollment at 3.2% and 4.7%. I'm sure there were many challenges in getting a higher percentage. But I also noted with interest the higher immunogenicity or humoral immune response. The one was consistent with the older age groups you did with the data you presented yesterday. And in particular, the 6 to 23 months, it was almost twofold higher than the white population or other populations. So one question I have for you, is this a real distance or are we victims of small numbers? Is there some significance to the trend of a higher immune response that you're seeing with the black participants? And then the second question, just to prime you, is with respect to the immunogenicity data set as a whole, is there any evidence of possible overrepresentation from individuals with higher titers, either of black race or perhaps even post-baseline infections?
Yeah, thank you for those questions. So let me first put up the slide looking at the immunogenicity by race. So those slides are, if you guys can find SY31. There we go. Oops, put the slide up, please. I just saw it, Michael. I don't know.
Okay, why don't you discuss it?
There we go.
Okay.
Yeah, there we go. So these are the children 2 to 5. The pattern is similar in the youngest infants. In the interest of time, I'm happy to show it, but I understand we're short of time. So as you mentioned, the immunogenicity cohort, which is, of course, a subset of the total cohort, there were 20 African-American children, and their titers were higher, but the 95% confidence intervals overlapped. And in terms of representation in the trial, I think we didn't see over-representation of groups that might have had reason to think that there were higher titers. So you see the proportion of the groups that had the highest titer in terms of race, and certainly in terms of seropositives, they were much less frequent than seronegatives. And I can show you in the toddlers as well if you want to see, or if you want to move on. It's up to you.
I think we can move on.
That's
I think we've, Dr. Fuller, final question.
I just wanted to follow up on the earlier question. I suspect that you're going to be looking at those things in the future, but my concern is that the one child that had the seizure, was there any underlying thing like sickle cell or asthma or anything that could be detected? Because even though there only may be one, if that's someone's child that can identify that they have a risk factor, that would be very useful to know.
Yes, Dr. Fuller. So we don't really have other medical history on that child. They were previously well. I will say, and I'll just add maybe for reference as a pediatrician, febrile seizures often happen in children who are healthy with no underlying conditions. So they occur at a rate of about 3% between the peak ages of 1 to 5. So it didn't necessarily surprise us that this was a child who had no otherwise underlying conditions.
So did you look at things, or will you look at things like sickle cell or that sort of thing in the future? I heard you mention immunocompromised earlier.
Yeah, no, so the trial in the immunocompromised is going to be specific and standalone. The power of our large effectiveness study in a diverse database like Kaiser Southern California really allows us to look at events by different underlying conditions, allows us to look at different age groups and so forth. And so certainly hear the interest in seeing what the effectiveness looks like in children with sickle cell. So we will look into that.
Oh, that's great.
Thank you. And thank you to the sponsor and to FDA for their answering our questions. We now move on to the discussion of the voting question and the vote. And what we're going to be doing, as usual, is having the committee discussion over the voting question. We will then vote, and then we will have explanation of votes for those who wish to explain their votes. So, do we have the voting question we're going to be discussing? Based on the totality of scientific evidence, do the benefits of Moderna's COVID-19 vaccine administered as a 2-dose series outweigh its risks for use in infants and children 6 months through 5 years of age? Discussion. Dr. Meisner, followed by Dr. Portnoy.
Thank you, Dr. Monto. I'd like to make a couple of comments in regard to this. I don't think anyone could listen to the open public hearing session without being troubled by the diversity and the emotional commitment that's been put into this issue of immunizing children in between 6 months and 5 years. It was quite moving. My personal feeling is that it would be hard not to include 6 months to 5 years of age in an amendment to the EUA in view of the strength of the data that we have seen today. But I would like to make this comment, and I think it's very important, as Dr. Cohn said yesterday, that the communication or the messaging be made as clear as possible for parents to understand the relative risk and the relative benefit. I think for example, we've heard several times that there were approximately 442 deaths so far in the pandemic among children less than 5. So that means about 220 deaths a year, approximately. And if you look at the number of people who are struck by lightning in the United States on a year, it's 270. So we're talking about a very rare event. If we talk about hospitalizations among children between 6 months and 5 years of age, the hospitalization rate on the CDC website the latest study, is 2.3 per 100,000, or 23 per million. And there are about 20 million children in this age group. So 20 times 23 is 460 hospitalizations associated with COVID in this age group that we're considering today. And probably only a fraction of those are because of COVID-19 infection rather than a coincidental association. So really we'd be talking about vaccinating close to 20 million children in order to prevent 200 or 300 deaths. And it's a matter of how an individual weighs the risk and benefit. I think the vaccine should be available for certainly high-risk children and for families that are so concerned they are troubled by that risk ratio, and they should have access to the vaccine. But I, again, feel very strongly parents should understand how small these numbers are. It's a very low risk from the vaccine, but it's also a very low risk from the infection itself. And I think that has to be communicated clearly to parents so that they can participate in the decision about vaccinating a child in this age group. Thank you.
Thank you. Dr. Portnoy, followed by Dr. Berger.
Great, thank you. I've really enjoyed this conversation, and I have to say I was extremely moved by the public comments as well. Nobody can not be moved by it. But I work at a children's hospital, and I remember earlier this year walking by the emergency room and looking in and seeing that the place was completely filled. I asked one of the security guards what's going on, and he said, well, it's COVID. The emergency room was filled. Our hospital was loaded up with children who had COVID. Now, I know that the death rate from COVID in young children may not be extremely high, but it's absolutely terrifying to parents to have their child be sick, have to go to the hospital, or even go to the emergency room or their primary care doctor because they're sick and having trouble breathing. So it's not just deaths. We have to understand how distressing this is for parents whose children are affected by this disease. Every pediatrician that I know at our hospital has been waiting eagerly for this vote to occur because they can't wait to start giving this vaccine. So our question today is the benefit outweigh the risk of this vaccine? And I think that the evidence is pretty clear for preventing severe disease, hospitalization, emergency visits. This vaccine is very effective. It's also very safe to use. I'm a little bit disappointed that it doesn't prevent infection by COVID as effectively as it could, because that's what spreads it around. But even in adults, we can't prevent infection, but at least we can stop people from being terribly sick. So this is a long-awaited vaccine. I feel the pain of those who are opposed to it, who've had bad experiences with it. They can choose simply to not get the vaccine. But there are so many parents who are absolutely desperate to get this vaccine, and I think we owe it to them to give them a choice to have the vaccine if they want to. Thank you.
Thank you, Dr. Berger, followed by Dr. Fuller.
Thank you as well. And I was going to say something similar to what Dr. Portnoy was pointing out is, it's not just about deaths, it's about preventing hospitalization. And, I think some of the, really distressing information that we've heard is that a quarter of those children that are going to the hospital are ending up in the ICU. And 63% of them have no underlying comorbidity to actually be directing this. And so you have to ask yourself, what other, those that do have comorbidities might be at a higher risk. And so it really is about giving a choice. But I actually had a question about the question we're being asked. And part of this is just the framing. All the data we've been given, and specifically the way it was collected, was dividing up the 6 month to 23 month olds from the 2 to 5 year olds. And yet the question is putting them all together. Now, this may not change the outcome, but it occurs to me that it's sort of an oddity in terms of the voting question itself that we're being presented with, because the data isn't exactly aligned 100% across both of those groups. there are slight differences in vaccine efficacy, and some of the side effects we've seen may not be significant. But I did have a question for FDA as to why it was combined in the voting question as opposed to having it be separated into those two different age groups for voting.
We have an answer from FDA, Dr. Fink.
Yeah, hi. So the EUA request from Moderna was for emergency use authorization of the 25 microgram dose level for use in the age group of 6 months through 5 years. So that is why the voting question is constructed accordingly. We yesterday dealt with 2 separate EUA amendment requests, one for adolescents, one for ages 6 through 11, and that's why those questions were constructed accordingly. I do recognize that that the data was presented according to the 2 smaller age groups within 6 months through 5 years, and for Pfizer, it was done the same. But I would hope that the committee would really focus on the similarities, and if they and consider the age group as a whole. And if they feel compelled, if any committee member feels compelled to have a different opinion for one smaller age group versus another, then of course you can raise that concern.
Thank you, and I am reminded that this is a discussion. Right now, we will have a second session after the vote in which you can explain your vote. So technically, you're not supposed to say how you are voting at the moment, but you can say whether you support or not the approval. Dr. Fuller, followed by Dr. Reingold.
Yes, that is what I was going to say, that the need for clear messaging to parents and guardians about the choice for having the vaccine or not is very important, and that the follow-up studies that are planned are very important. The benefits seem to clearly outweigh the risk, particularly for those with young children who may be in kindergarten or in collective child care, so that those who want to do this will have that option. But I would ask, should this pass, or should this be recommended by FDA and by the advisory committee and passed by FDA and CDC, that parents really consult their pediatrician for their children. My question earlier wasn't just for sickle cell, but any other unknown underlying condition that might impact the outcome. So this is a decision that parents and grandparents and guardians will have to carefully weigh should this actually go through.
Thank you, Dr. Reingold, followed by Dr. Sawyer.
So thanks. One of the speakers in the public session urged us multiple times to think of the children. Now, I think he and I might think of the children in slightly different ways. But my way of thinking about the children is that if we have a vaccine whose benefits outweigh the risks, that making it available to people is a reasonable choice. I would point out that we as a country continue to give a large number of vaccines to children where the risk of the child dying or being hospitalized of those diseases is pretty close to zero. Those include polio, those include measles. We vaccinate large numbers of people against HPV, even though very few of them would ever develop cancer related to HPV. So we, with our vaccines, are trying to minimize serious illness and death, or perhaps reintroduction of something like polio into the United States. But we generally know that many of the infections that we are vaccinating against, the serious outcomes are quite rare, actually, and we nevertheless try and vaccinate a large part of the population, if not everyone. So I think we do need to focus on the serious outcomes, and even if they're relatively infrequent, And even if a vaccine is less than 100% effective, flu is another good example. We continue to recommend flu vaccine for people, even though it only may be 30 to 40% effective. And so if we have a prevention opportunity, I believe we should take it. But just one last caveat. My personal preferred wording is not to tell people that something is safe. I think that's the wrong messaging. I think nothing in life is perfectly safe. No drug, no vaccine, no personal choice to get on a plane or get into a car is, quote, safe. I think what we need to emphasize is that the benefits outweigh the risks. Thank you.
Thank you, Dr. Sawyer, followed by Dr. Levy.
First of all, I'm generally in support of approval for many of the reasons that have been outlined. To follow up Dr. Reingold's comment, I would like to add to the benefit column the fact that, as we heard in the public comment, some parents are so concerned about the risk of exposure that they're still completely isolating their children socially, perhaps above and beyond what the current CDC and AAP guidelines suggest. And the potential adverse impact of that isolation was brought up also in the public comment session. So the availability of these vaccines will liberate those children to some extent whose parents will find relief and feel a little more comfortable to let their children start to socialize in the appropriate environment. The other potential benefit that's been touched on is the impact on long COVID, which has further potential challenges for development as we learn more about what long COVID does and what the implications are for school performance. So I think there's a lot in favor of the benefit column in the risk-benefit equation.
Thank you, Dr. Sawyer. Dr. Levy, last question so far.
Thank you. I am generally supportive of this direction, and I also want to emphasize the importance of knowledge and that we keep building on our knowledge. We saw a lot of good information today, including some immunogenicity information, but as I mentioned yesterday, we have a ways to go to understand the correlates of protection against coronavirus. Antibodies are likely very important, but not the whole story. We'd like to see T-cell data. We'd like a recognition that correlates may be age-specific. You might get a similar antibody response at a given age, but antibodies act in a context together with the complement system, with phagocytes, and those systems might be distinct by age due to immune ontogeny. So I encourage FDA and the sponsors to continue to develop more sophisticated and nuanced information about correlates of protection. The other key here will be safety surveillance. The possibility of febrile seizures, particularly in those unusual cases where there's a high fever after the vaccine in the young age groups. It's possible we'll see febrile seizures as this gets pushed out, if indeed that's the determination by FDA. So we have to keep an eye on that. And also potential impact on other balance of other respiratory infections, as what was alluded to by FDA, by Dr. Doron Fink. So those are areas that I think where knowledge it needs to continue to evolve. But overall, I'm supportive. It's a bioethical concept of a presumption of inclusion. We have reasonable safety data, and this vulnerable population should be included. And there's a broader context. This platform, this mRNA vaccine platform, may be useful not just against this current coronavirus and its current variants, but the next ones, as well as future pandemics. Thank you.
Thank you, Dr. Levy. That concludes the questioning, the comments concerning the voting question. We will now have the vote, and then we will have explanations from those who wish to explain their vote further.
Thank you, Dr. Monto. Only are 10 regular members and 11 temporary voting members. A total of 21 will be voting in today's meeting. With regards to the voting process, Dr. Monto will read the final voting question for the record, and afterwards, all regular voting members and temporary voting members will cast their vote by selecting one of the voting options, which include
yes, no, or abstain. You will have 2 minutes to cast your vote after the question is read. And please note that once you have cast your vote, you may change your vote within the 2-minute time frame. However, once the poll has closed, all votes will be considered final. Once all the votes have been placed, we will broadcast the vote results and read the individual votes out loud for the public record. Does anyone have any questions related to the voting process before we begin? Okay. Okay, Dr. Monto, if you could please read the voting question.
For the record, based on the totality of scientific evidence available, do the benefits of the Moderna COVID-19 vaccine when administered as a 2-dose series, 25 micrograms each dose, outweigh its risks for use in infants and children 6 months through 5 years of age?
Okay, please pull up the voting pod. At this time, you may start to vote. Okay, it looks like all the votes are in. We can go ahead and close the poll. Thank you. Okay. There are a total of 21 voting members for today's meeting, and the vote is unanimous. We have 21 out of 21 yes votes, 0 no votes, and 0 abstain votes. Okay, I will now read specific votes for the record. Okay. Dr. Berger, yes. Dr. Nelson, yes. Dr. Fuller, yes. Dr. Levy, yes. Dr. Monto, yes. Dr. Sawyer, yes. Dr. Offit, yes. Dr. Reingold, yes. Dr. Bernstein, yes. Dr. McKinnon, yes. Dr. Wharton, yes. Dr. Pergin, yes. Dr. Chatterjee, yes. Dr. Portnoy, yes. Dr. Lee, yes. Dr. Kim, yes. Dr. Cohn, yes. Dr. Morosco, yes. Dr. Meisner, yes. Dr. Hildreth, yes. Dr. Gans, yes. And that completes my reading of the vote. And I will hand the meeting back over to Dr. Monto.
Now we will proceed to explanations of the vote from anybody who wishes to speak. Dr. Hildreth.
Thank you, Dr. Monto. I think the evidence that we had in front of us justified a vote of yes. I do want to make a point that I made yesterday, Dr. Meisner made a few minutes ago. We got to be transparent about the real risk of COVID-19 for children. Tens of millions of children in this age group have been infected and have done just fine. So I think we need to make parents aware of what the real risks are and let them make decisions. But for those parents who choose to do so, especially those parents of kids with underlying conditions, this is a choice they should have, and I'm pleased they don't have it. Thank you.
Thank you. Dr. Portnoy.
Thank you. As a designated consumer representative, member of the committee, I can speak on behalf of the patients that I take care of. I know that there are a lot of very relieved parents almost certainly, who are listening to this right now. They've been waiting for a very long time. I again want to emphasize how terrified parents get when their children get sick, even if they don't die from it. I take care of patients who have food allergy. The number of deaths from food allergy is extremely low, and yet the parents are terribly anxious and worried about this disease. COVID actually causes a lot more deaths. I understand why parents are very nervous and fearful of doing normal activities, and especially if their child actually catches COVID. But even the fear that they could catch COVID, this will certainly alleviate a lot of their concerns. And so I'm really happy that the vote went the way it is. I think it was the right vote. Thank you.
Thank you. And Dr. Nelson.
Thank you, Dr. Monto. I do believe the benefits far outweigh the risks that were involved. And personally, I really do believe this recommendation does fill a significant unmet need for a really ignored younger population in need of options. Families will now have choice that they did not have before, and I fully believe in the intelligence of families to make the right choice for their family and children, particularly when we provide clear recommendations with respect to the information we have on hand regarding the risk and benefits. My personal hope that every child in the U.S. seeks and gets vaccinated in the near future. Thank you, Dr. Monto.
Thank you. Dr. Bernstein.
Thanks, Dr. Monto. I want to express my agreement with everyone else. With over 600 million COVID vaccine doses that have been already administered in the U.S., the overall safety profiles are quite reassuring. And I think having a COVID vaccine available for this younger population is critically important, given that pediatric cases can be, have been, and may be problematic in the future. I also think that there's a huge vaccine safety monitoring system in the United States that's historic. And so that should be reassuring to many. And I do think that there are advances in science, in the COVID-19 science. They'll continue on for many years, not just vaccines, but treatments and testing and social distancing, masks, etc. I also think that hybrid immunity will provide more protection against future infections and will be helpful as well, even to those who have already experienced COVID. Because I think overall, those who are vaccinated tend to do better in all outcomes than those that are unvaccinated. And I think that the ultimate aim of COVID-19 vaccine is to prevent severe disease, hospitalization, and death more than preventing transmission and infection. And I think the messages, I want to emphasize what others have said, that messaging must be communicated very clearly to the public. And I still feel that there are tens of millions of people who are unvaccinated, and we must also encourage them to get vaccinated. Thanks.
Thank you, Dr. Levy, followed by Dr. Gans.
Yeah, I just wanted to take a moment to acknowledge the public commentary that shows the wide diversity of opinions in the U.S. public about this whole vaccine enterprise. And I think it becomes important that we continue that tradition of being open to all the public commentary, provided it's not hate speech, provided it's respectful, but to cast a big tent here. And I think what we've heard from a lot of the committee members, they'll each speak for themselves, but what I've heard is the emphasis on a choice for families. They can partner with their pediatrician, make a decision. If they're in a situation in a community where there's a lot of spread of COVID, if they have children that may be at higher risk, if they have family members who are particularly vulnerable, we encourage them, if this moves forward, to avail themselves of this option. So it's a concept of making it available. And the ongoing safety surveillance, the U.S. public should hear that that's a serious enterprise. It's not a rubber stamp. We've seen entire vaccine programs put on hold for rare cases of thrombosis. And I was interviewed in the media saying, Dr. Levy, isn't it a mistake? Doesn't it shake public confidence when they stop a program? I said, to the contrary, it should show the public that the safety surveillance works, that it's serious, and that if we do detect further signals that are concerning, something will be done about it. So I think this is the right path forward, and I'm very honored to be part of this committee. Thank you.
Thank you, Dr. Levy. Dr. Gans, followed by Dr. Marasco.
Thank you very much. I just wanted to add a voice to the significance of this as a pediatric disease. I think as you weigh it in terms of being the fourth and fifth most risk factor for death is really an important. So I think we really do need to not underplay the importance of this as a pediatric disease, and therefore prevention is really the way to go. It's also of note, and was brought up earlier, that there are just all these treatments now that we have for COVID, but that's not the case for our youngest individuals. We actually have very restricted and limited ability to help anyone who's infected, and they are actually not the most efficacious. And so I think it's very important. The other point I wanted to bring up for the individuals who will be considering this for their families is that infection, the immune response that you can get from vaccine versus infection is different. When you have an infection and you have viral replication and also tissue invasion and damage is different. You do get an immune response, but getting an immune response without that is also should be an option for individuals so that they don't have to suffer from the actual viral disease. So I think that's a really important point that hasn't been raised. I'm trying not to be repetitive for my colleagues, so I know I've raised some really great points. The other aspect I would like to just add to Dr. Levy's point and others on this committee is that we do take the science very seriously. And I hope that really has come through to those who maybe are doubting the fact that we're listening. We are considering all of the different scientific, and I just want to applaud the scientific community. This is really a breakthrough that has allowed us to move through the pandemic in a way that has allowed less suffering and disease. So I'm very glad for this option for people in the scientific community who care for children as well as families. Thank you.
Thank you, Dr. Gans. Dr. Marasco, followed by Dr. Lee.
Hi, thank you, Dr. Marty. So I've been impressed, as everybody has, with the comments by the public. They're very important. I take them seriously. I think we all do. It has not escaped me or other members of the committee that we've received thousands upon thousands of emails from people on both sides of this issue. I think it's really been largely a matter of misinformation or disinformation, people thinking that children weren't as susceptible as they were, earlier in the pandemic. I don't think many people understand the increase in infection with Omicron, but I think it's all about people making their own decisions for themselves and their family. Dr. Meisner and everybody else has really said it right. It's a matter of choice. I just want to make sure the messaging from the CDC and the FDA is coordinated in such a way that the healthcare providers, the local healthcare providers can also provide that information to help families and parents make this decision. So I'm proud to be part of this committee, and I agree with the decision that's been made.
Dr. Lee.
Yes, I just wanted to also add my support for this decision. I think
as we heard in the public comment, the lack of the vaccines for these young children has been a gap for many and has really had an impact on their lives. So I think this is really, really very positive. I will say I think it's clear the story isn't over. The pandemic has taken some different twists and turns, and there may be more options for these children in the future, and I think we will be considering that as well. And I'd also like to say I'm very proud to be part of this committee and very, very pleased with all the science we've been able to see from the investigators and the companies. Thank you.
Thank you, Dr. Lee. That concludes our action on the Moderna vaccine. We're going to take a break until 3:25 Eastern. That gives us about 15 minutes. Is that right?
No, 10 minutes. 3:25. Yeah, 15 minutes. Yes, you are right.
Yeah. Yep. A reward for getting done. We'll start when we should have been taking the break. 15 minutes. And then we will repeat what we've just done. Questions, discussion, and vote for Pfizer.
All right. And with that, we will now take our 15-minute break. Studio. Studio, can you tell us if we're clear? Okay, good afternoon and welcome to the closing session of the 174th Vaccines and Related Biological Products Advisory Committee meeting. Dr. Ana Monto, our chair, take it away.
Thank you very much. We will now repeat the process of questions to both the sponsors and to FDA, and then a discussion and votes and explanation of votes. So hands raised for questions for either the sponsor or FDA, Dr. Marasco, followed by Dr. Gantz.
Dr. Gruber, thank you, Dr. Monto. Dr. Gruber, this is a question for you. And it's a question that was touched on by Dr. Program, Courtney, and Offit, and it really has to do with your 3 microgram dose. So there's a pretty impressive step up in protection from your second and third dose for Omicron. And I at a pretty low dose of mRNA, and I heard from your associate that, you've got good protein production. But the question I really am asking is there a fundamental difference that has occurred with your vaccine? In other words, because of the low dose that you have given, are you getting any different quantitative or qualitative response in terms of, for example, higher affinity antibodies? So when you do your titering and you get your mean geometric titer, you get a number, but is that because of higher titer antibodies, higher titers, or more higher affinity to the Omicron? And those kind of studies can be done quite simply serologically, and I'm wondering if you're pursuing that to find out if there's something qualitatively and quantitatively different about the effect you see in your third dose.
Thanks for the question. I may ask Keena Swanson to actually come up to provide maybe a little bit more detail, but to this point, we haven't actually specifically looked in detail, certainly in the pediatric population, about the nature of antibody affinity. I come back to the fundamental observation that as best as we can determine, the level of neutralizing antibody that we see against Omicron seems to reliably predict the likelihood that you're going to have protection. When that antibody is low, regardless of whether it's related to affinity or related to the actual quantity of antibody that's there that has neutralizing potential, it predicts the likelihood that you're going to be successful. Low antibody, less efficacy. Higher antibody, higher efficacy. And again, we've shown that antibody that we induce in these young children matches that in older adults in older children and adults after 3 doses and provides protection. But maybe I can ask Dr. Swanson just to comment on any other sort of work that we're doing related to characterizing antibody.
Hi, Keena Swanson from Pfizer Viral Vaccines. And just to add briefly to what Dr. Gruber mentioned, I think the key of what we're seeing in the development of the immune response is between the second and the third dose. There is not only an increase in the neutralizing titer, but the activity and binding affinity of those antibodies, particularly that you can notice against Omicron. And that's been seen in the data in the adults, and we're seeing indications that the trend is similar as well in children less than 5 years of age. And there are other publications and preprints out there that have done, similar analysis in other populations.
Thank you.
Yeah, maybe if I can just enlarge on a point, because I want to clarify something that was being said this morning that this really interdigitates with, and that is that both in the briefing document as well as in the information that the FDA shared with you in their slide presentation, you've seen Kaplan-Meier curves. And for the 2 to 4-year-olds, it's pretty clear that whether we're talking about Delta or we're talking about Omicron, even after the second dose, you do see a spreading of those curves. And if you think about it, the amount of Delta that we saw is actually dwarfed by the amount of Omicron. So much of that efficacy that you're seeing even after the second dose is due to efficacy against Omicron. For the 6 months to less than 2-year-olds, it's less clear about when that efficacy may start to occur, but you can see as you go farther out that the curve begins to spread a little bit. And the goal really is, with the third dose, to move everything to the left, to maximize the potential that we can have for protection against Omicron by giving that third dose.
Dr.
Thank you. Dr. Gans?
Thank you. And I think I would love to hear some of the vision of what Pfizer is going to do. We heard quite a bit from Moderna about some of the studies that they're going to be doing forthcoming. And thank you for providing the ones that we heard about earlier today. We don't have to repeat those. The ones that I was really considering is it's not unusual to need a prime boost strategy, so the 3 doses here doesn't surprise many people, and I think that's all within keeping. My question for you, particularly because these were developed during a time when there's obviously disease progression, variants coming into being, what will be your follow-up studies? How likely is it that and probably pretty likely because we're seeing that in the adult population, but what are you doing to prepare for future doses? And are you looking at any other dosing in terms of how much you're giving and the intervals?
Yeah, so thanks for that question. We're obviously all looking forward to the end of this month when at the VRBPAC further decisions on the nature of what future vaccines should look like will be informed, both by information that we're providing based on our bivalent vaccine experience and our Omicron experience in adults. We are actually working then based on the information that comes out of that meeting to best tailor what we would do to investigate young children. And as is no surprise to you, Dr. Gans, we have sort of 2 groups we have to contend with here. Those that are naive, what's going to be best for them moving forward, as well as those that we put in good position, we hope, based on hopefully today's recommendation from the VRBPAC committee, to have them fully primed, ready for whatever else we might bring in the future.
Thank you. And thanks both to the sponsor and to the FDA group. We have no more questions from the panel, and therefore we will move to discussion of the voting question. And could we have the voting question put up? So, based on totality of evidence, do the benefits of the Pfizer-BioNTech COVID vaccine, when administered as a 3-dose series, outweigh its risks for use in infants and children 6 months through 4 years of age? That is going to be our voting question. Now, discussion. We don't want to say how you're voting, but you can say whether you support approval. So, Dr. Offit.
Thanks, Arnold. So I think that the way that this question is written, do the benefits outweigh the risks, is something I could support, but I do have some concerns about this vaccine. I just want to sort of air them. It does worry me, actually, that there was no protection after dose 2. That was surprising. I think it was probably surprising to the company. And I fear that they may have underdosed. We were supposed to meet on February 15th to discuss this. We didn't, I think, in part because those data probably were surprising. And with Moderna, you have, for example, low levels of protective efficacy after dose 2, but you can assume that probably is predictive of better protection against severe disease. I'm not so sure you can predict that with Pfizer's vaccine. Now, on the other hand, with the 3rd dose, you get the kind of immunobridging data that is reassuring. The neutralizing antibodies against Omicron is reassuring, but that's dose 3. So for people who've gotten that vaccine, who've gotten, say, 2 doses of that vaccine, they have to know they're not protected, and they're going to have to wait a few months till they are protected. And I just wonder whether parents will understand that. So I do worry about this because I think it was a surprisingly negative result. And although the protective efficacy that was listed, with 75% for the 6-month-old to 2-year-old and 80% for the older group, those are based on very small numbers. I mean, it's seven cases in one instance, 3 cases in another. It's just a little hard to put to feel comfortable about that since the numbers were so low. So I do support this, but I do worry that parents aren't necessarily going to know that after 2 doses they may not be protected at all and would engage the kind of activity that would put their child at risk. So thank you.
Dr. Offit, would you be more comfortable if in the post-approval period careful surveillance be given about protection after 2 doses, given the relatively small numbers? Is this something that can't be fixed?
Yeah, no, I think that's a really good point. And we'll, as more and more children are vaccinated, we'll learn more. And it may be that what Dr. Cohn said earlier is true, that this may end up being a 4-dose vaccine. But I do think we should certainly learn as much as we can when it gets out there. I think it's safe. I think it will certainly offer something. But I do worry that those 2-dose data were surprisingly poor. So, but thank you.
Hey, Dr. Chatterjee, followed by Dr. Lee.
Thank you, Dr. Monto. I was actually going to make a very similar comment to what Dr. Offit did with regard to the 2 doses not providing sufficient protection. I think with 2 vaccines that have different dosing regimens, it's going to be even more important than ever that the public education, the education of providers, is done very, very carefully so that people understand what the ramifications of the choices that was discussed earlier this afternoon are. That we are making choices between 2 different vaccines that have a little bit different profiles, and that's going to be important for people to take into consideration. Having said that, I would say that I was pleased to see the 3-dose data showing that it brings it up to par, basically like we see in older children and adults, to the level of protection, recognizing, of course, that this virus is continually changing and that those numbers are maybe true today and may not be true down the road. But with all of those caveats, I am in support of the authorization of this vaccine as well, making sure, again, that the education around this is done very, very carefully so that people are not misled by what the vaccines actually provide.
Yes, and I think we should not underestimate the problems of rolling out various approaches to vaccination, which have different intervals and different doses and the rest. This is going to be quite challenging. Dr. Lee, followed by Dr. Cohen.
Yes, thank you. So I share the concerns of the last 2 speakers about the 2-dose data. I was also actually quite surprised. I guess my concern is I do recognize that with the 3 doses, there's certainly benefit. I have a lot of concern that many of these kids will not get the 3rd dose. As we know, it's a struggle to get people in for 2. We've already seen with the boosters for adults, lots of people don't take them. And so my concern is, since you have to get the 3 doses to really get what you need, I'm just concerned that that some won't. Having said that, I will say that I am supportive of this, though. Thank you.
Dr. Cohen, and then Dr. Marks is going to be making some comments.
I am also very supportive and agree that the benefits do outweigh the risk of this vaccine. Just to add to what the previous commenters have said, I think it is imperative that we do post-licensure surveillance for effectiveness for both vaccines, but in particular, I'm also concerned about people comparing the VE estimates or point estimates between these 2, which I think is a real problem given the few number of cases. And I would really hope in our communications that we not use that 80% effectiveness, because my level of confidence in that number, I believe the vaccine is effective. I do not have any idea what that number will actually end up being. And additionally, I think it's really important for people to understand that this was effectiveness after 30 days. Other vaccines have looked at effectiveness after longer periods of time of follow-up. So 30 days after vaccination, this could fall off very quickly, and we just want to monitor it closely.
Yeah, Dr. Cohen, you noticed the confidence intervals around some of these estimates, correct? We really can't go with the point estimates because the confidence intervals for a lot of them were pretty wide until you grouped together. Dr. Marks, you had some comments?
I just thought it might be helpful. I apologize if I missed this, but I didn't hear the sponsor reply to this. But it may be helpful. There does seem to be a lot of mystery around the second dose effectiveness with Pfizer, and it might be helpful for both the public and for the committee if they commented on that 2-dose effectiveness.
Okay, that's fine. I remember they're saying that the Kaplan-Meier plots did separate. Dr. Gruber, would you supplement the information we've got?
Yes. So again, there are really 2 lines of evidence. We've already spent time showing the slides in terms of the Delta response, right? And for both age groups after a second dose, we had high levels of efficacy, both in the 6-month to less than 2-year-olds. In the individuals that were 2 to 5, we also demonstrated efficacy after Delta. The real question, obviously, in an Omicron environment is what we're seeing after Omicron. And if my slide pullers can pull it up, or people can likely remember it, or you may see it in your briefing document. Again, if you looked at the 2 to less than 5-year-olds, you see separation of the curve. Let's bring slide 1 to screen, please. So keep in mind, again, that we have a total of 10 cases in terms of post-dose 3. So most of the cases that you're seeing here represent cases after dose 2. And you can see, based on the x-axis, the number of days and sort of calculate then, well, if it's 21 days between the first dose and the second dose, because this is a Kaplan-Meier based on the time from the first dose, you can see spreading of the curve that starts fairly early and then continues to spread in the 2 to 4-year-olds. So it's not as if there's no efficacy at all. The notion is we're building on a level of efficacy that in every other population we regard as insufficient for Omicron, and the goal here, based on what we're showing you with the 3rd dose, is to improve upon that efficacy. If we then show, if you put slide 1 up, please. So slide 1, in this case, we're talking about the 6-month to 2-year-olds. And it's true that as you walk through most of the period of time here, you're not seeing a separation of the curves. But given that there are a total of 3 cases, some of that separation at the end may well be due to maturation of immune response and the fact that those children now are beginning to show some evidence of efficacy. But the goal with the 3rd dose in this circumstance is to shift that to the left, where we essentially can build upon the ability to provide some protection against disease by moving that separation of the curve to the left. And keep in mind, again, as with every other circumstance, there's some expectation that protection against severe disease is likely to be higher than what we're seeing against just symptomatic infection. So hopefully, Dr. Marks, that helps clarify.
Thank you.
I appreciate it.
Thanks, Dr. Marsh. Thanks, Dr. Gruber. And Dr. Gans, it looks like you are going to have the final word in our discussion.
Thank you. I just wanted to point out, as a lot of people have pointed out, particularly that there's 3 doses needed here to provide protection. But in terms of what the public and parents should expect, it's likely that Moderna is also going to be a 3-dose schedule. And so I just wanted to put that into context of what we understand. And that doesn't take away from the comments that my colleagues have already provided for the feelings that we have about these different vaccines. Thank you.
Thank you, Dr. Gans. No more hands raised, so we move to the vote. Christina.
Thank you, Dr. Monto. Okay. Can you please, let's go down to the next slide.
Let's get the right question up.
Okay. As you can see before us on the slide, here are the members and temporary voting members that will be voting. And then Dr. Monto, if you could please read the voting question.
Okay. Based on the totality of scientific evidence available, do the benefits of the Pfizer-BioNTech COVID-19 vaccine, when administered as a 3-dose series, 3 micrograms each dose, outweigh its risks for use in infants and children 6 months through 4 years of age?
Okay, at this time you can go ahead and vote. You have 2 minutes to vote. Okay, it looks like all the votes are in. You can go ahead and close the poll and broadcast the results. Okay. There are 21 total voting members, and we have here 21 yes votes. This is a unanimous vote, and there are 0 no votes and 0 abstain. And now I will go ahead and read the specific voting responses for the record. Dr. Berger, yes. Dr. Nelson, yes. Dr. Fuller, yes. Dr. Levy, yes. Dr. Monto, yes. Dr. Sawyer, yes. Dr. Offit, yes. Dr. Reingold, yes. Dr. Bernstein, yes. Dr. McInnes, yes. Dr. Wharton, yes. Dr. Pergam, yes. Dr. Chatterjee, yes. Dr. Portnoy, yes. Dr. Lee, yes. Dr. Kim, yes. Dr. Cohn, yes. Dr. Marasco, yes. Dr. Meisner, yes. Dr. Gens, yes. Dr. Hildreth, yes. And that concludes my reading of the specific votes, and I will now hand the meeting back over to Dr. Monto.
Thank you. And before I hand we have an explanation of votes. So, Dr. Levy.
Yeah, I just wanted to offer some thoughts here. I'm really pleased that we've reached this kind of milestone. I recall our first vote a year ago or more on the first Pfizer authorization. I was one of the 17 votes in favor. I remember those early discussions. Even then, should the 16 and 17-year-olds be included? At that point, that was a controversial topic that was being discussed. And here we are now as a committee unanimously recommending authorization down to 6 months of age. So we've come a long way. The Warp Speed vaccine initiative more or less worked. It got us safe and effective vaccines in record time. But I just want to make the point that there's a lot of work to do ahead in vaccinology. We have inequities globally in access to the vaccines. I'll point out that the majority of the vaccine infrastructure in the world is pediatric, and pediatric vaccines achieve higher population penetration for that reason. So that's something interesting to contemplate. as we think about global inequities in immunization against this pandemic. The other point I'll point out, and it was evident in the discussion, is the number of doses required. 2, 3, maybe 4 in immunocompromised individuals, maybe 5. So we're very fortunate to have safe and effective vaccines in record time, and yet still, we can't all go home now. There's a lot of work, a lot of research still to be done. Can we design vaccines that give single-shot protection, that cover all of the different variants, that are pan-coronavirus vaccines? Are vaccine adjuvants a potential approach to get better efficacy with 1 or 2 doses instead of needing 3, 4, or 5 doses? So this is a public plea to keep supporting around the globe vaccine research so that we can have even better vaccines in the future. Thank you.
Dr. Nelson.
Thank you, Dr. Monto. Just a couple of quick comments. Clearly in favor of the voted question as voted. Having options at every age group is important, and certainly this second vote contributes to that and does contribute to options and choice for families throughout the United States. 2 quick comments / caveats. I do think there is certainly needed data to look specifically at the stratification of both the immune response and the reactogenicity based on the interval between that second and third dose. We saw a discordance today with the immunogenicity data generated early, but the safety data with the larger groups spread out throughout that entire period. And with the numbers involved, I'm not sure we have the full signal of where that benefit-risk ratio is for that third dose. To me, it probably looks closer to a vaccine like hepatitis B, where there is evidence that that third dose actually given later might work. But in this case, with the gap in efficacy, apparently having it closer to that second dose may be advantageous. And would certainly, if families are listening, err towards that direction. And then finally, the co-administration issue that has come up over and over today is something that I too have been concerned about going into today's discussion. I'm glad to hear that our sponsors are going to look into the question. I will tell you that if we don't get a quick answer to the co-administration question, it will serve as a barrier to completion of these 3-dose series for this vaccine and likely the Moderna vaccine. Having to get it in isolation is going to be a great challenge for families and children here in the U.S. Thank you, Dr. Monto.
Thank you, Dr. Nelson. Dr. Fuller, followed by Dr. Chatterjee.
Yes, thank you, Dr. Monto. I just want to say that the idea of having Pfizer and Moderna is very good for families, and also that we should not forget that the mitigations of masking and these things that work, that we know work, should not be forgotten, even with those who are vaccinated, because we don't understand the reinfections or the new infections with new strains. So people need to be reminded in the messaging the importance of the things that we do know that works, such as distancing and just being careful and using what we know. And so I'm very pleased that we have 2 opportunities to help those with younger families, and there's a lot of work still ahead to be done.
Thank you, Dr. Chatterjee.
Yes, thank you, Dr. Monto. As a pediatrician, today is a red letter day for me. To be able to vote for authorization of 2 vaccines that will protect children down to 6 months of age against this deadly virus is a very, very important thing. And I am also thinking back, like Dr. Levy, to December 10th, 2020, which is the day that we authorized the very first vaccine for use in people who are 16 years of age and older. And I was actually one of the no votes, which got me into a lot of trouble. But the reasoning behind that, and we were able to explain that later, was the 4 of us who voted no that day all had essentially the same reasoning, I believe, and that was that we had insufficient data in the 16 and 17-year-olds. We had data only on 150 participants when the ongoing study had 2,000 in it. If we had just waited a little longer, we would have had those data. it's interesting to think back to that time, but it's also important to look forward, as Dr. Levy has pointed out. There is much work still to be done against this virus and against other infectious disease threats that face our population. And so I am just very, very grateful to have been part of this effort, and I'm delighted that we have been able to recommend authorization for these two vaccines for our very youngest children. Thank you.
Thank you, Dr. Cohen, and then Dr. Pergam.
Thanks. I just wanted to say quickly, I'm obviously, as a pediatrician, super happy that we can now vaccinate down to 6 months of age. But really, I just want to express my deep gratitude and admiration for the staff at FDA who have made this happen, because my confidence in this vote today is entirely related to the just clearly incredible amount of work that many, many staff at FDA have put in. I can't even, the number of people who have presented and put this all together is incredible. And I know we have another meeting in 2 weeks and the work is not done, but I just think taking a moment and thanking the staff that put all this effort into this, I just wanted to do that.
Dr. Cohen, you're stealing my closing remarks, but I'm still going to say it when we get to the close. Dr. Pergam.
I just laughed because Amanda always has such great comments, and always appreciated by other members of the committee. I can say that. I do think it is important that as we have this discussion about the importance of having two vaccines available for children, that as the FDA thinks about this and CDC in terms of providing vaccine across the country, that, you know, when the primary vaccine doses were given, Moderna and Pfizer were not adequately distributed in different parts of the country. And so I think it's really important that both of these options are available throughout. And we're in a different situation with vaccine availability than we were in the past, but I think it's going to be really contingent upon both to provide both of these options throughout the U.S. and not have specific locations where one or the other is offered. I think it's really important, since these are different. There are different caveats that parents may look at when they're offering these to children or making decisions, that I think it's critical that they're made available across the country.
Dr. Meisner.
Thank you, Dr. Monto. One very brief comment, similar to my comment regarding Moderna. I think it's the right decision today to make these vaccines available for this age group. But I also think it's important that people understand it's a small number of children who have received these vaccines, and the safety is not as well established as it is in adolescents and adults. So it's so important to continue to follow the safety profile of these vaccines. I don't think they should be required for any specific situation. Thank you.
Thank you, Dr. Meisner. Dr. Marks, do you want to make any closing comments? And after that, I'd like to make some closing comments.
Yeah, no, thanks, Dr. Monto. So I'm going to, I think Amanda started it very nicely, but I just want to just summarize that, you know, the past 2 days, we heard excellent presentations from sponsors, from FDA. We heard open public hearing speakers, and I think it is a bit of a milestone to bring down the age range for these vaccines as we work through this. I also think we heard we have to be aware of the fact that we care tremendously at FDA about the safety, effectiveness of these vaccines, and we will continue to monitor these vaccines as they are deployed. I would just remind the public that VAERS is a method that captures all adverse events, and causality in VAERS is not, it's not established. there seems to be a lot of misinformation, and I'm saying it right now in real time because I'm watching Twitter storms in front of me about misunderstanding VAERS. VAERS, anyone is able to submit an adverse event to VAERS. We actually require that certain things be submitted to VAERS, and so it can, from casual inspection of VAERS, look like there are things that are associated with the vaccines, but until one sorts through that, one does not know what is truly associated with the vaccines. And indeed, we have experts that spend a lot of time and that pride themselves. They work day and night to ensure that they understand the safety profile of these vaccines. That has been done and will continue to be done diligently. And as we have findings, as we did with myocarditis, thrombosis thrombocytopenia syndrome, Guillain-Barré syndrome for rare adverse events, we will make sure the public knows about them. So I just want to say that, want to just remind people of that and just take a final moment to thank the committee members for an incredible amount of time, and thank our FDA staff who have really worked beyond anything that could ever have been expected of them, from the advisory committee staff to those helping to run today's meeting technically, to those reviewers and management in the Office of Vaccines and the Office of Biostatistics and Pharmacovigilance and Biologics Quality, who have relentlessly worked on this. Very grateful for all their work. Thank you, and thank you, Dr. Monto, for chairing this meeting. I'll turn it back over to you.
And I wanted to thank you, Dr. Marks, and your staff for an enormous amount of work that's gone into this. I was glad to hear our committee members remember back to December 10th, 2020, when we first approved a vaccine for SARS-CoV-2 virus, and the fact that there were negative votes, and we've now, a year and a half later, almost to the day, approved a vaccine for down to age 6 months of age. So essentially all of the American population can now choose or be chosen to get vaccine. And we had some negative votes there. And I remember that we didn't even have time because we were running over and all sorts of things going on because of the pressure to get vaccines approved at that point. And we didn't have the time to have individuals like Dr. Chatterjee explain their vote, which wasn't against the vaccine, but the fact that we didn't have sufficient data. What's happened since that time is that we have had observational studies which have guided us in terms of the parade of variants that we've had since that time, the need for booster doses, and now, a year and a half later, we've got pediatric vaccines approved down to age 6 months. Why a year and a half? Because of a lot of things that have happened over that time. It has not been easy. And to say that there have been delays, unnecessary delays, is not representing the true situation, which involved not working with adults, but with a vulnerable younger population for whom special care is necessary. So in closing, I would like to let the public know how hard Dr. Marks and the entire staff at FDA have worked to reach this milestone. When we organize these meetings, emails come in at 11 o'clock at night. Over the weekend, people are working overtime to get the public availability of these nearly miraculous vaccines. I work in flu, where if we have 50, 60% effectiveness, that's pretty good. And here we have vaccines which are highly effective in preventing severe disease. So I'm very delighted to have had the privilege of chairing these sessions in getting us these very critically important vaccines. I just wish everybody would realize how well they work in preventing severe disease. I would like to close this meeting and hand this over for the official closing to Dr. Atreya. And thank you, Dr. Atreya. We've got and I hope you get some rest so you don't have to send me emails at 11 o'clock at night when I can't read things through my regular email system. Thank you.
No problem. Thank you all. With that, with those closing comments, I really thank the whole committee and the staff and involved in working really hard and making these meetings successful. I greatly appreciate. So with that, I officially adjourn the meeting for today. Thank you all and namaste.
All right, and with that, this meeting has been officially adjourned. Any questions or comments, please send them to our email address and have a great day. Studio, please end the meeting.